It is a pleasure to meet you again this year. It is now becoming a tradition to come to join the University of Plovdiv. And it is a pleasure to start immediately with the presentation. You know that we have the honor to have with us the former rector of this university, Professor Murjeva. And it is a pleasure to me to introduce her before she is giving her lesson with a representative target that we prepared the ONLUS Black Sea and Mediterranean Medical Candidate prepared for her because she has been the star for our organization. Please. And I think that we start now immediately with Professor Murjeva presentation on macrobiological aspects of post-surgical joint infection. Please, Professor Murjeva. Professor Sivkov and Professor Marcavolo are the president of this session, so they have to start the work.
I'm sorry I'll interrupt for a while and read two letters, one from the rector of Medical University and one from the president of Bulgarian Republic of Bulgaria. So first is I'll read in Bulgarian and Giovanni will translate into English. First is the rector's letter. До организаторите и участниците на курс по анатомична хирургия. По зрителен адрес по случай 10-то издание на българо-италиански курс по анатомична хирургия 24-25 ноември 23 година Пловдив. Уважаеми организатори, уважаеми колеги и гости, от името на академичното ръководство на Медицинския университет Пловдив, за мен е удоволствие и привилегия да поздравя организаторите, презентаторите и участниците в 10-то издание на курс по анатомична хирургия от рамена до киткова става и от тазобедрена до глезена става. Изказвам адмирации към лекторите и модераторите, изтъкнати учени от България и Италия, които за поредна година се събират, за да обменят опит и добри практики, да поручат най-съвременните медицински постижения. Форумът още веднъж доказва, че Медицинския университет Пловдив е с поглед към бъдещето, като събира на едно място специалисти, практикуващи лекари и студенти от двете страни. Включването на предаване на живо гарантира, че знанията, споделени по време на курса, ще достигнат до глобална аудитория. Медицинския университет Пловдив е ваш верен партньор по пътя към професионалното развитие. Успех на форума. Ректор на Медицинския университет Пловдив, професор Лучиков. Giovanni.
Dear organizers, dear colleagues and guests, on behalf of the academic body of Medical University Plovdiv, it is a pleasure to congratulate all guest speakers and participants of the 10th edition of this anatomical surgical course. The forum once again proves that the Medical University Plovdiv gathers specialists, medical doctors and students from Bulgaria and Italy to share good practices and experience, and their knowledge will reach the global audience through live streaming. Medical University Plovdiv is and will be your partner during your professional development. Good luck.
Now the letter from the president. Уважаеми професор Роза, уважаеми господин ректор, уважаеми организатори и гости на събитието. Бих искал да ви поздравя по повод 10-та годишна от провеждането на ежегодния курс по медицина. Съвместно да организира днешното събитие от Фондация Черноморско-Средиземноморска здравна академия и Медицински университет Пловдив е неоспоримо доказателство за ценното сътрудничество и дългогодишната традиция, която сплотява опита и познанията на българските и италиански университетски преподаватели в областта на ортопедията, травматологията, анатомията и хирургията. Уверен съм, че и тази година курсът ще бъде успешен, защото е насочен към младите лекари и специализанти, които са амбицирани и мотивирани да добият нови знания и практики в учебните зали. Надявам се тази традиция на академичен и приложен обмен да се запази и развие бъдеще. Адмирирам ползотворното партньорство между българските и италианските лекари и работа им в областта на научно-изследователската и образователна дейност, в сферата на медицината и полза на пациенти с ограничени финансови възможности. Използвам възможността, за да отправя на всички участници в инициативата своите искрени благопожелания за здраве, благополучие и нови успехи. 24 ноември 2023 година, президент на Република България Румен Радев.
Salutation letter of the President of the Republic of Bulgaria, General Rumen Radev. So, dear Rector, I would like to congratulate you on the 10th anniversary of the annual course in medicine. The joint organization of today's event by the Black Sea Mediterranean Health Academy Foundation and the Medical University of Plovdiv is undisputable proof of valuable cooperation and long-standing tradition that unites the experience and knowledge of Bulgarian and Italian university lecturers in the fields of orthopedics, traumatology, anatomy, and surgery. I am confident that this year's course will be successful, as it is aimed at young doctors and specialists who are ambitious and motivated to acquire new knowledge and practices in the lecture halls. I hope that this tradition of academic and applied exchange will be preserved and developed in the future. I admire the productive partnership between Bulgarian and Italian doctors and their work in the fields of scientific research and educational activities in medicine, benefiting patients with limited financial resources. I take this opportunity to extend my sincere wishes for health, well-being, and new successes to all participants in the initiative.
Okay. Now, Professor Pop Stefanov. Professor Pop Stefanov will read letter from Professor Kamburov.
Уважаеми гости, уважаеми колеги, скъпи специализанти! За съжаление не съм в състояние да участвам лично в тазгодишното юбилейно 10-то издание на вече традиционния курс хирургична анатомия. С гордост отбелязваме тази важна годишнина, свидетелство за ангажимента на Фондацията Черноморско-Средиземноморска медицинска академия през всичките тези години в подкрепа на университетското сътрудничество между България и Италия. Чест за мен е да мога да приветствам с няколко думи тази специална среща. Този курс представлява пресечна точка и среща между разнообразни медицински култури и академични традиции и насърчава обмена на знания и опит между колегите. Въпреки че сме физически разделени, ние сме единни в страстта си към медицината и желанието за учене и растеж заедно. Не мога в момента да участвам във вашия престижен форум, но сърцето ми е с вас на тази среща. Пожелавам на всички 2 дни изпълнени с учене, споделяне на опит и моменти на професионален и личен растеж. Надявам се, че това издание ще бъде още една стъпка към още по-близкото и плодотворно сътрудничество между нашите институции. Благодаря за вашето посвещение и приноса в тази инициатива. Да работим. Професор Камбуров.
Salutation letter by Professor Kamburov, the Bulgarian president of the Black Sea and Mediterranean Medical Academy Foundation. Dear guests, esteemed colleagues, dear specialists, unfortunately I am unable to personally participate in this year's jubilee, the 10th edition of the now traditional course Surgical Anatomy. We proudly mark this important anniversary, a testament to the commitment of the Black Sea Mediterranean Medical Academy Foundation over all these years, supporting university cooperation between Bulgaria and Italy. It is an honor for me to be able to greet this special meeting with a few words. This course represents a crossroads and meeting point between diverse medical cultures and academic traditions, and encourages the exchange of knowledge and experience among colleagues. Although we are physically separated, we are united in our passion for medicine and the desire to learn and grow together. I am currently unable to participate in your prestigious forum, but my heart is with you at this meeting. I wish everyone 2 days filled with learning, sharing experiences, and moments of professional and personal growth. I hope that this edition will be another step towards even closer and more fruitful cooperation between our institution. Thank you for your dedication and contribution to this initiative. Let's work.
Thank you. And now, a few words from one of the coordinators of the course, Professor Stavrev.
Okay, I'll speak in English so that everybody can understand me. As you heard from my previous speakers, it has become a tradition because this is the 10th edition of this course. And this course is mainly dedicated to the guests from Italy, the Italian students, the Italian young doctors. I'm proud to be a coordinator of this course. And I'm also proud that some of my scholars, like for example, Marta Ferrando from Genoa, first she attended the course many years ago, then she decided to become orthopedic surgeon, and after she became an orthopedic surgeon, she made a PhD thesis because she stayed on the basis of the Erasmus Plus program for 6 months in our department of orthopedic surgery, which is the biggest department in Bulgaria, with 70 beds and 24 hours emergency. And she's already an orthopedic surgeon in Genoa. And 1 year ago, she came again because she missed Bulgaria. I hope that you will like the show because you will have the chance not only to see PowerPoint presentations, but also to do some practical stuff in the Department of Anatomy, where we have prepared cadavers for you to test and to see in real life the actual approaches to different parts of the human body. So I'm happy that this tradition is going on, and I believe that this tradition will go on in the future. I wish that some of you become orthopedic surgeons like your colleague from Genoa, Marta Ferrando. Thank you.
Good morning. Just a couple of words. Just a couple of words to thank the organizers of the course and the medical university which hosts this event. On my name, on behalf of the Italian ambassador to Bulgaria, His Excellency Giuseppina Zarra, we wish you a fruitful course. And I want to stress that this course, this event, is a key moment of the relationship between our two countries, Bulgaria and Italy, in a very important sector, which is healthcare. I'm sure that during these 2 days you will learn a lot of new things and you will improve your abilities and skills. And I'm quite sure that after the course you will enjoy the nightlife in this beautiful town, Plovdiv. So good luck, and I hope to see you again next year. Thanks.
And please, Mr. Santurelli, next speech is from you.
Good morning. Thank you very much. Sorry for the delay, had a misunderstanding. I arrived in time. Ladies and gentlemen, I would like to thank you, the president of the Black Sea and Mediterranean Medical Academy Foundation, Dr. Michele Attilio Rosa, for inviting me to the inauguration of the anatomical surgery course, which is celebrating its 10th anniversary this year. I also express my gratitude to the rector of the University of Medicine in Plovdiv, Dr. Angel Uchikov, and Dr. Marianna Murjeva for supporting these important initiatives over the years, renewing scientific cooperation between Italy and Bulgaria. Education and research are very important. Confindustria supports and collaborates with the universities, bridging the skills gap between work and education, and applying the academic research to the industry for the development of innovative tools and machinery that are implemented also in hospitals and medical centers. I hope that the government can evaluate and subsidize the cooperation between industry and university and the collaborative activities like this one to stimulate cross-border projects. I wish you a good work and a great day. Thank you.
Okay, the last two speeches from Professor Macauro and me to open the course, of course, opening words. Please.
Oh, good morning. Thank you very much for the invitation. Thanks to the University of Plovdiv. Thanks to the honorary embassy of Plovdiv. I think that it's time to begin the course after some words, and I invited Professor Murjeva to finally to have her presentation, hoping that in the future we improve our cooperation between our university, because it's very important to cooperate between different countries and different university, and especially taking into account some aspect of research in orthopedic research, and especially taking into account on the infections. So thank you very much, Ms. Professor Murjeva. Please come in, and we declare open the session.
I should not miss my words, sorry. You're bored, I think you're bored, but it's a few seconds more. Dear guest colleagues and students, I feel extremely glad to welcome everyone to this awaited course, and it gives me immense pleasure to be standing in front of you. Thank you to each of you for being here with us today. We are very pleased to be able to welcome those of you who have been with us before, and those who come for the first time. Today we mark our 10th year anniversary of the course of anatomic surgery, and we are proud to be able to host it today here at this wonderful place. Today I would like to focus on all our new participants who have joined the course. Our participant in the course your participation in the course is due to a mutual passion for Black Sea and Mediterranean Medical Academy mission. We need you as much as you need us, and that's why we are grateful to have you join us here at the 10th course of anatomical surgery. During the next 2 days, you will be learning about the anatomy and its clinical correlates. You will be practicing new surgical methods and skills, and most important, you'll be able to join in and get hands-on experience. I hope this will help you grow to be more productive and smarter. I don't want to take too much of the time, and we have to start the course with the next speaker. This is Professor Murjeva. She waited too much for this. I wish you good luck.
Good morning. We can speak. We can beginning the first section with the first election with the Miss Dr. Mariana Murjeva that speak about the microbiological aspect of the post-surgical joint infection. Please.
Thank you, dear Professor Rosa. Dear Mr. Chairman, dear faculty members, and dear students, it is a great pleasure for me to be again a part of this course, which is organized by the Black Sea and Mediterranean Health Academy. And this is a jubilee course for this academy and for the initiators of it. So I'm really honored to be again here, and I remember 10 years ago in 2013 when we hosted the course. I was the Vice Rector of International Relations and Project Activity at that time, and it was a real challenge not only for me but for all my colleagues being at the Medical University of Plovdiv to host the course. And I think we managed to do this course for years. I think just the COVID pandemics interrupted the course for 1 or 2 years, I don't remember exactly. So now after 10 years we are together with most of you, and some of you are new members of this academy and they will profit from this course. And as a medical doctor, microbiologist and immunologist, each year I give a topic focused on microbiological aspects of joint infections, but with different focus, either on elbow or on knee or on shoulder, on other joints. Now in this course, not because it's a jubilee course, I will focus your attention in general on these joint infections. And I will talk about the post-surgical infections in orthopedic surgery. What are those infections, how they are classified? These are very propedeutic characteristics of the infections. They're focused for students mainly. Then I'll go, because the microbiology is in the very essence of this lecture, then I will go on etiological agents of these infections. And finally, microbiological diagnostics, what are its basic characteristics and what procedures you should follow in order to get the result from the microbiological laboratory. And why this topic? Because infections are serious complications after orthopedic surgery, and the Center for Disease Control and Prevention, the CDC in the States, estimates that within 30 days those infections appear, and as many as 3 out of 100 surgical patients will develop an infection. Also because those infections are associated with prolonged hospital stay and mortality, so that's why they're a very serious problem in surgery. And what are surgical site infections actually? In general, in clean wounds, or the so-called closed, uninfected wounds, the surgical site infection includes incisional and organ space infections. And nearly more than 2% of operations each year in surgery, no surgical specialties, are complicated with such surgical site infections. These complications occur in 2 to 5% of patients after clean extra-abdominal operations, and in up to 20% of patients undergoing intra-abdominal procedures, where the risk of contamination of the wound is really very high because of the presence of gut bacteria in the abdominal cavity, in gut. And the mortality rate increases 2-3 times after infection. But what about in orthopedic surgery? Approximately 1 to 5% of wounds develop a superficial or deep infections in clean orthopedic operations. This is mainly total hip, shoulder, and knee replacement. And here are some data about the global incidence of the so-called clean or closed uninfected wound infections after orthopedic surgery. You can see that this is the global incidence in mean is 2.5% according to NEL. And then we have the highest incidence in India, 5%. Then in Brazil, Turkey, Italy is 2.6%, the middle of it, United States, and France, the lowest, 1%. So this is according to literature data. And this is a very good slide, which is taken from Kadler and his paper, published 8 years ago, about the causes of prosthesis failure in orthopedic patients. So you can see that the first figure is for knee prosthesis, and here with the star, these are the causes for failure in knee prosthesis that are due to prosthetic joint infection, and then aseptic loosening with the black color and mechanical failure. If we go to hip prosthesis, we will see that this percentage here with the star is lower than the knee prosthesis, and it is very high in shoulder prosthesis here. About three-fourths of this failure may be due to prosthetic joint infections. What are the etiological agents that participate in surgical site infections in orthopedics? These are mainly bacteria, and the first place is occupied by Staphylococcus aureus, which is a normal habitat of our human skin, and it is most commonly spread by direct contact and airborne routes. And however, Staphylococcus aureus thrives in the nares of nearly 25% of the population. And this is the most commonly isolated microorganism also in osteomyelitis. The second strain you can see is Staphylococcus epidermidis, or other staphylococci that are in the group of the so-called coagulase negative staphylococci. They are different from Staphylococcus aureus. Staphylococcus coagulase negative are also normal residents of the human skin, mouth, and the nose. And these bacteria, rather than Staphylococcus aureus, have a distinct affinity for plastic, especially for prosthetic devices. So they also are one of the common contaminants of orthopedic prosthesis. And furthermore, some of these bacteria, Staphylococci, are resistant to beta-lactams. For Staphylococcus aureus, we use this term MRSA, which means methicillin-resistant Staphylococcus aureus, and this means that they're resistant to all beta-lactam antibiotics, and we cannot treat these infections with these antibiotics, such as penicillins and especially cephalosporins. And there is also increasing rate of methicillin-resistant Staphylococcus epidermidis, which are found with this abbreviation MRSE. Then, in the red color, we have the so-called gram-negative etiological agents of these infections. Staphylococci and Enterococci are gram-positive, but these gram-negatives are found in our gut, and usually they come from the gut or as intra-hospital infections, nosocomial infections. So these are Klebsiella, Enterobacter, Pseudomonas species, Acinetobacter species, Proteus mirabilis, and Citrobacter. And furthermore, we may have also polymicrobial etiology of such surgical site infections in orthopedics. Viruses and fungi and parasites are found in rare conditions in these patients with surgical site infections. Viruses are found as causative agents of these infections in dirty or infected wounds, and they may be a result of generalized infection. For example, you can see in the slide that alpha viruses, hepatitis B virus, rubella virus, and parvoviruses may contribute to such infections of the joint. And fungi and parasites may be found as causative agents of surgical site infections in orthopedics in immunocompromised patients. This is a good study which was published in Croatian Medical Journal from Serbian authors. The incidence of surgical site infections in orthopedic ward. So 277 patients after operation were examined, and surgical site infections in general were found in 63 of them. So this is 22.7% in general for all surgical site infections. The clean surgical site infections in clean wounds were 13%, then going through 65% for contaminated wounds, and in infected or dirty wounds, they, you see, go to 70%. This is another study for incidence of surgical site infections in geriatric orthopedic surgery. So Staphylococcus aureus, as you can see, occupies more than half of the agents that contribute to such infections. Then we go to Staphylococci, which are coagulase negative. And in nearly half of these cases, the occupation is caused by MRSA, methicillin-resistant Staphylococcus aureus, which I mentioned before. These are microorganisms that are isolated from 53 culture-positive surgical site infections. We can see again the leading role of Staphylococcus aureus, nearly 30% in these infections, and most of them were resistant to penicillin or to main beta-lactam antibiotics. And then you can see that there is a plenty of gram-negative microorganisms, which shows that it's probably a nosocomial infections for these patients, being infected with Acinetobacter, Klebsiella enterobacter, Pseudomonas, Enterococcus, Proteus, Citrobacter, and so on. These are patterns of isolating polymicrobial infections. This is in Uganda, a case study in Uganda with combination of bacterial pathogens isolated on culture from wound swabs collected at one surgical site from a participant. So again, we can see the great role of Staphylococcus aureus, but also combined with Klebsiella. So this here, the blue color, means polymicrobial infection between Staphylococcus aureus and Klebsiella, and then in 12% of the cases, this infection is occupied by Klebsiella in association with Enterococci. So this is a great challenge for such a ward, because you should treat such infections probably with 2 antibiotics or with broad spectrum antibiotics. And imagine that Staphylococcus aureus is methicillin resistant. That means you should include beta-lactams and include other antibiotics. And we made a similar study for post-surgical infections in university hospital, in our university hospital, in the orthopedic clinic. So we found the same tendency. That study was made in 2017 and 2018. And here you can see that, again, we have the leading role of Staphylococcus aureus of such infections. And to a minor extent, the role is led by coagulase negative Staphylococci, but we also have gram-negative positive agents of such infections, such as Acinetobacter, Pseudomonas, E. coli, and Enterobacter. And this is the proportion between gram-positive and gram-negatives in such infections. So in nearly 30 to 40% of cases here, we have gram-positives in such infections, and in 66% the gram-negatives in these 2 years, which is not a very good sign, because these are, as I said, nosocomial infections mainly. About shoulder replacement and surgical site infections, some interesting data that we also find such infections in shoulder replacement. In conventional implants, the statistics shows that it's about 1%, but in reverse implants, more than 3 times higher, 3.8%. And now we come to the microbiological diagnosis of orthopedic infections. The microbiological diagnosis starts not in the laboratory. It starts from the correct specimen collection and transport. So you, as future orthopedic surgeons, are responsible for such proper collection of the specimen. What can you collect? You can collect various specimens such as pus, synovial fluid, tissue samples, blood, prosthetic components, or even the entire prosthesis. And then you should put these materials, if possible, if they are in small proportions, in broad-necked containers with a transport medium, Amias or Stuart are preferable. And then when these specimens come to the lab, we can make zonification, if it's a fluid, synovial fluid. We do this culture in blood culture vials like these ones. Probably you've heard about them or used them. They contain media which is very good for cultivation of microorganisms that eventually are present in the synovial fluid. And it was found that this type of culture is more sensitive than the others, than the intraoperative swab cultures. You can take swabs like this, but the zonification of synovial fluid in blood culture vials is more sensitive, and you see that the sensitivity reaches 92%, whereas in proceeding the intraoperative swab cultures it is 68-76%, and in tissue cultures, when we make tissue cultures, this is about 77-80%. And then one thing which is very important, you should try to culture or to send the specimen at least 3 times to the microbiological lab. The polymicrobial nature of prosthetic joint infections supports the routine use of an assortment of media suitable for recovery of fastidious, slow-growing, anaerobic, and also sublaterally damaged bacteria. So some studies support an incubation period not for 3 days, but for 14 days. And here I should point out that the microbiological diagnosis should be very fast. So this is very important, and thanks to some pharmaceutical companies, so we have now the possibility to do such diagnosis using multiplex polymerase chain reaction and other fast methods. So culture negative infections in orthopedic surgery do not mean that you don't have an etiological agent in this surgical site infection. Culture techniques usually detect bacteria that cause acute infections with reasonable sensitivity and accuracy, but are not very effective in detection of bacteria in chronic biofilm infections. So we use non-cultural techniques as well. This is the perspective. This is multiplex PCR, fluorescent in situ analysis, and confocal and electron microscopy, which unfortunately is not suitable for all microbiological laboratories. So this is a slide here which shows a confocal light micrograph of stain preparation scraped from the surface of a culture negative acetabulum cup, and hundreds of orange round Staphylococcus epidermidis are seen to have colonized some elements of the tissue. So all those orange structures are staphylococci here. So we should break the chain of infection, and first we start with the infectious agent with its correct microbiological diagnosis, whether it's bacterium, which bacterium, virus, fungi, protozoa, or parasite. Then we go to analyze the susceptible hosts, whether these are cancer patients, if they are subject of operation, if they are immunocompromised, such as also elderly patients, surgical patients, patients with burns, diabetes mellitus, etc. Then we should break the link, the portal of entry, then the mode of transmission, which may be via direct contact, airborne droplets, or vector-borne. Then to break the link of the portal of exit, excretions, secretions, and droplets, urinary catheters, venous catheters, arterial catheters also may be colonized. And following this colonization through blood, the infection may reach the prosthesis or the joint. Then the reservoir are very important to be analyzed and to be identified, the people, the equipment, the water. and prompt treatment, decontamination, rapid identification of organisms are these crucial procedures. Now, some key issues of perioperative antibiotic prophylaxis, which is recommended in orthopedic and trauma surgery requiring device implantation through open surgery, such as joint replacement and osteosynthesis. The choice of antibiotic for this prophylaxis is very important. First or second generation cephalosporins. This is the recommendation, and there is an alternative. These are glycopeptides or clindamycin in case of allergy of the patient, or high incidence of MRSA infection in the ward. So consider combination with antibiotics, active on gram-negative in specific local situations. The first dose, and usually it's a single dose, is recommended to be put within 30-60 minutes prior incision, and this is again first or second generation cephalosporins, and 2 hours before surgery for vancomycin. The timing, you should maintain adequate serum and tissue levels for the whole length of procedure, redosing if beyond 2 half-lives of the selected antibiotic. And the duration, as I said, the duration for this prophylaxis, not for treatment, but for prophylaxis, is a single dose or short-term prophylaxis, 24 hours administration in certain cases. And as a conclusion, there are numerous etiological agents that cause post-surgical infections. In orthopedics, mainly bacteria with the predominant role of Staphylococcus aureus. Infections may occur in both natural and artificial joints. People with artificial joints are more at risk than the general population. Periprosthetic joint infection remains a very common cause of failure of shoulder, hip and knee arthroplasty. Microbiological diagnosis is important, but pre- and post-debridement cultures do not appear to be constantly predictive of infection or infecting bacteria. Initial choice of adequate early intravenous antimicrobial agents can reduce infections in comorbid patients, and antimicrobial prophylaxis in orthopedic surgery lowers the rate of post-operative infections. Thank you again for your attention.
Thank you for the exhaustive presentation.
Next 3 lectures of this first part of the morning session are on the basis of topography of the anatomy. So our next speaker is from the Department of Plovdiv. This is Professor Delchev. His talk will be on the topographical anatomy of the shoulder region. So we invite him to join us here.
Dear moderators, dear presidents of the Academy, dear colleagues, dear guests, my topic is focused on the shoulder region. Shoulder region is the proximal segment of the upper limb and also overlaps with the adjacent parts of the thorax and back. The lateral neck also belongs here. The regions that are included are pectoral, scapular, deltoid, and greater supraclavicular fossa of the lateral cervical region. This drawing shows the boundaries of each region: deltoid, pectoral, scapular region. Axilla is also involved here. We'll begin with the deltoid region, which is the main part of the shoulder. The boundaries coincide with those of the deltoid muscle, anterior and posterior borders of muscle, clavicle and acromion proximally. The layers are as follows: skin, subcutaneous layer, deltoid fascia, deltoid muscle, subdeltoid space, rotator cuff muscles, and shoulder joint. We'll follow these layers. Skin is soft and movable. Deep to skin is the subcutaneous tissue, which contains fat and sensory branches of the axillary nerve. Deltoid fascia covers the muscle and descends from the clavicle and the acromion. Anteriorly, it continues to pectoral fascia, posteriorly to infraspinous fascia. septa from the deltoid fascia penetrate between the muscle fibers of the deltoid and separate it in smaller compartments. Fascia that covers muscles on the surface of scapula forms osteofibrous compartments, which allows muscles to have greater mass and strength. The name of these layers are according to their location. We have supraspinous fascia, infraspinous fascia, subscapular fascia located anteriorly. Pectoral fascia encloses pectoralis major muscle. At its lateral border, it becomes axillary fascia, which forms the floor of axilla. The deep layer of pectoral fascia is named clavipectoral fascia. It covers and encloses pectoralis minor and subclavius muscle and protects the axillary vessels and branches of the axillary brachial plexus in the axillary fossa. Pectoralis major is a large fan-shaped muscle with 3 heads. It has clavicular head, sternocostal, and abdominal head. They converge in massive tendon that attaches to the lateral lip of intertubercular sulcus. The muscle is adductor in the shoulder joint and medially rotates arm, innervated by pectoral nerves. Pectoralis minor arises from 3rd to 5th rib and attaches to the coracoid process. It stabilizes scapula. It draws scapula anteriorly and inferiorly. Subclavius is a small muscle between first rib and excuse me, clavicle. It anchors clavicle and stabilizes the shoulder joint. Between the pectoralis major and deltoid, there is so-called deltopectoral sulcus, and here we can find cephalic vein and deltoid branch of thoracochromial artery. You'll see it after that. 6 muscles belong to scapulohumeral group of muscles, intrinsic muscles of shoulder. They are listed here. Relatively short muscles that pass from scapula to humerus, and the main action is in the glenohumeral joint. The next layer is the deltoid muscle, which is laterally and superiorly to the shoulder joint. It has 3 parts according to their origin: clavicular part, acromial, and spinous part. Muscle inserts on deltoid tuberosity, laterally on humerus. I'm sure you know its function. It is the main abductor in the shoulder joint, assisted by infraspinatus. It also participates in flexion and extension of shoulder joint and medial and lateral rotation, innervated by axillary nerve. The next layer is presented by subdeltoid space. It contains bursae, usually 2, subdeltoid and subacromial bursae, sometimes connected and named as one bursa. Bursae are located over greater tubercle and tendon of infraspinatus, so they facilitate movements of these muscles, infraspinatus and deltoid, over the greater tubercle. These bursae usually do not communicate with the cavity of the shoulder joint. The next muscle is teres major, which originates from the external dorsal surface of the inferior angle of scapula and attaches to the medial lip of intertubercular sulcus. You can see it here. It adducts arm and medially rotates. It is important for the stability of the shoulder joint. Innervation from subscapular and thoracodorsal nerves. Next 4 muscles form so-called rotator cuff. Their abbreviations are SITS, sits muscles. They hold the relatively large head of humerus in the shallow glenoid fossa. Their tendons surround the shoulder joint according to their attachment. You can see this. Supraspinatus muscle originates from supraspinous fossa and fascia. attaches to the superior facet of greater tubercle. Its function is to initiate abduction, initial 15 degrees of abduction, assists deltoid. The next muscle is infraspinatus, which originates from the same fossa, infraspinatus fossa, and attaches to the middle facet of the greater tubercle. It is a lateral rotator of arm. Both muscles are supplied by suprascapular nerve. Teres minor is a narrow muscle, originates from the lateral border of scapula. It is not clearly delineated from infraspinatus and attaches to the inferior facet of the greater tubercle. The function of this muscle laterally rotates arm, and it receives innervation from the axillary nerve. Subscapularis originates from the costal surface of scapula, attaches to the lesser tubercle. Its tendon adheres to the fibrous capsule of the shoulder joint. The function of this muscle, it medially rotates arm and adducts arm, and it also prevents injuries of the fibrous capsule of the shoulder joint. Two important communications are found between these muscles. We have quadrangular space and triangular space shown here. We'll not talk about the boundaries. They transmit neurovascular bundles. Quadrangular space, here we have axillary nerve and posterior circumflex humeral artery and vein, which go to subdeltoid space. You can see these vessels and nerve here. Triangular space transmits circumflex scapular artery and vein to the scapular region. Location of these vessels and axillary nerve is usually at the midpoint of the posterior border of deltoid, 6 centimeters below the chromion. Cadaver dissections show that the location of axillary is between 4 and 8 centimeters below the chromion. Usually it is accepted 5 to 6 centimeters to avoid injuries of the nerve and the artery. The next layer is formed by bones. The lateral end of clavicle, which is flat and articulates with the medial border of acromion. There are joints formed here. Acromion and coracoacromial ligament with coracoid process form protective arch over the shoulder joint. Coracoid process can be found 2.5 centimeters below the clavicle. 3 muscles attached to the coracoid process. Pectoralis minor superiorly, coracobrachialis medially, and the short head of biceps brachii. Proximal part of humerus is also in this region. It has 2 tubercles, greater lesser and intertubercular sulcus or groove. Sternoclavicular joint is a saddle type of joint but acts as ball and socket. There is a disc and strong ligaments. Acromioclavicular joint is flat. The movements are combined into these 2 joints. So we have elevation and depression of shoulder, protraction and retraction around the vertical axis, and rotation around the longitudinal axis of clavicle. And scapula can move laterally and medially about 60 degrees. Shoulder joint, the most important of this region. Excuse me. Ball and socket joint. The humeral head is hemispherical, larger than the glenoid fossa. Usually between 25 and 30% of the head are in contact with the glenoid fossa. They are incongruent, and we have glenoid labrum, which increases the surface of the glenoid cavity. It stabilizes statically the joint, and dynamically the joint is stabilized by muscles, deltoid and rotator cuff. The fibrous capsule attaches at the margins of the glenoid fossa and to the anatomical neck of humerus. There are communications to adjacent bursae. Ligaments reinforce the joint. We have glenohumeral ligament anteriorly, coracohumeral superiorly to the tubercles, and transverse humeral, which bridges over the intertubercular sulcus, and coracochromial, which forms protective arch and prevents superior displacement of the joint. A tendon of the long head of biceps passes through the joint, and it is covered with synovial sheath. Movements of the joint, classically we have flexion and extension around the transverse axis. Here is the range of movement. Abduction and adduction around the sagittal axis, 90 degrees of abduction. Medial and lateral rotation along longitudinal axis, not shown here. It passes through the center of the head of humerus and capitulum. And circumduction, an additional movement. Deep to shoulder joint is axilla. It is pyramidal space. We will not talk about the boundaries. Some of the muscles described before form the walls of axilla. It has anterior, posterior, medial, and lateral walls. The apex of the pyramid is between the clavicle and the first rib, and here is the communication between the neck and upper limb. Axilla contains axillary vessels, axillary artery and vein, lymph nodes, and branches of the brachial plexus. Axillary artery is a continuation of subclavian after the first rib. It is divided into three parts according to the pectoralis minor and gives off the following branches. Thoracoacromial branch is important for this region. It pierces the clavipectoral fascia and divides into acromial, pectoral, deltoid branch and small subclavian. Subclavius branch. Deltoid accompanies cephalic vein in deltopectoral sulcus. There are also branches of subclavian artery, such as suprascapular and dorsal scapular, which is continuation of the transverse cervical artery. They form anastomosis around the scapula on its posterior surface, important for the blood supply. Some variations can find here. Sometimes subscapular artery arise from a common trunk with posterior circumflex humeral artery in 30%, or posterior circumflex artery may be replaced from the deltoid branch of deep brachial artery, profunda brachii, and passes below teres major instead of through the quadrangular space. Vein, the main vein is axillary vein, which is infero-anteriorly located to the artery. It receives branches that correspond to the names of the arteries, with two exceptions: cephalic vein and thoracoepigastric vein. Group of axillary lymph nodes, 20 to 30, distributed into 5 groups: pectoral, subscapular, humeral or lateral, central, and apical or infraclavicular. According to their location, they receive lymph from specific regions, and they are important for pathology in this region. Here are the lymph nodes. Apical continue as subclavian trunk. The nerves, branches of the brachial plexus, it comes from the neck. We have trunks, superior, middle, and inferior. They belong to the supraclavicular part of the brachial plexus, and here we have some collateral branches. Below the clavicle is the infraclavicular part, which gives off collateral branches and terminal branches of cords. You can identify chords according to their location to the axillary artery, lateral medial and posterior. Because we are limited of time, I will not give details about these branches. Each branch supplies muscles of the upper limb and will identify them in the cadavers. So we'll meet you in the dissection course in our rooms. Thank you for your attention.
Thank you for the presentation, and we continue with the topographic anatomy of the elbow.
Dear Chairman, dear guest friends and students, I'm glad to see my students here and all there. So, the elbow is not so vulnerable joint and region as the shoulder one, not so long, but quite essential in our everyday activities. Traumas are not so rare, and especially in some sports, it is habitual. That's why I'm going to stress on the elbow in relation to its clinical importance, and of course anatomy, the basis of anatomy should be used in clinics. So the region, elbow region, is identified with arbitrary lines passing through the epicondyles, bony lines that can easily be identified. And down we can see the two musculoeminences that meet along the midline, and you see this in this triangle are connected to a lot of structures packed together, close, tight, and this can be one of the reasons that it's so vulnerable region. So the ligaments and tendons are the first to be damaged. That's why we're going to stress first on them. We have two collateral ligaments. Always when we have a hinge joint, we have collateral ligaments, lateral and medial. Annual ligament is essential for this movement that we can perform here, pronation and supination. And quadratic ligament is hidden one. You have never seen this, I know, but I mentioned. So this is hidden that stabilizes the radial ulnar joint, the proximal. There are two tendons, biceps, distal biceps tendon and distal triceps tendon, which are essential here because of their basic function of the joint, but also because around this we have important muscles that are quite often inflamed. So it clinically correlates with this one. The medial collateral ligament has three portions. You can see this here. These three portions. Anterior bundle, it's inserted on the coronary process of the ulna and originates from the medial condyle. This medial condyle is one of the most important structures here. It stands on extension, so it limits the extension of this joint. Posterior bundle is also on the medial crown of the ulna and originates from the medial epicondyle of the humerus. It stands on flexion. So two bands which are tense during different periods of movements of the elbow joint. There is also one transverse ligament here and here. It is actually thickening the capsule and stretches between the orbicranial process here and the coronary process here. The row is not so important for stability of the joint, but anyway, we have to mention and know this because of the vulnerability of the joint. You see when these ligaments are tensed and what the position of the joint, these are the two bands that are most often stressed, anterior and posterior, and these are the angles when you can see which ligament is most stressed and which ligament band is most likely to be damaged. So spots are most often the reason for this vulnerability, but also some occupations also give this chance of habitual damage of the elbow joint. So you see, the golfer's elbow is often discussed in our classes, in our lessons. These are small tears here, close to the epicondyle, where the origin of the plexus of the forearm are found in the superficial group of muscles. We discussed this, all these originate common tendon from this epicondyle. So this is one of the most vulnerable areas of the elbow. Golfer, of course, there are a lot of other sports that can cause this damage, but it's a kind of mnemonic to know what happens with where. The other collateral ligament is the lateral collateral ligament. It originates, it's one here, originates from the lateral epicondyle of the humerus. It's under the extensor digitorum muscle and blends with the annual ligament. The annual ligament that encircles the head of the radius. We have three primary structures here: the radial collateral ligament, the proper one here. Then we have the annual ligament, this one, around the head, and the lateral ulnar collateral ligament. So two collateral ligaments, ulnar and radial here. Although we are on the side of the radius, we also have ulnar collateral ligament. Pay attention to this. This one, the lateral collateral ulnar ligament, is the primary stabilizer in lateral rotation. We don't use the term lateral rotation. We use different terms. We use supination and pronation for this movement. But anyway, lateral rotation is also possible as a term. Posterior one, posterior ligament, buttresses to prevent radial capitular subluxation. You know that between the radius, the head of the radius, and capitulum of the humerus, we also have a joint, and it can be subluxated, swiped. Accessory lateral collateral ligament is not always present. It's from the annual ligament to the supinated crest downward. It moves downward. You may find this, or maybe absent, you'll see during your practice. You may find some bundles of this. And you see what happens with this lateral collateral ligament when this is backhand, most popular sports, but quite different to perform. And it quite often causes these small tears inside the common tendon of the extensor muscles. But ligaments, collateral ligaments can also be involved. The quadrate ligament, we mentioned this, is a fibrous band attached to the inferior border, this one here. Inferior border of the radial notch, this one here. And the neck of the radius. So it is strengthened by fibers from the ulnar ligament. It is not only one structure, it achieves help from nearby. It secures, it reinforces the inferior part of the capsule between radius and thumb. And it secures the proximal radius against the radial notch. The radius should be kept there to perform the proper movement. You know what happens when you have this painful pronation, pronounced dolorous. So this one helps to keep the head of the radius close to the notch. And it will also restrict excessive supination. It's more important in terms of supination, and to a lesser extent the pronation. You see, more important in case of supination and less in case of pronation, but always tensed. Bursae are also important structures. We always discuss these synovial structures, communicating or not communicating with the joint. These are necessary to alleviate the friction between the tendons, muscles, and the bones, and of course to prevent some aseptic inflammation. We have bursae that are related to the olecranon here, superficial olecranon bursae, subtendinous, the triceps is here, and intratendinous within the fibers of the tendon, and also cubital bursae. The cubitoradial, where the biceps attaches to the radial tuberosity, and interosseous bursae is along the side of the brachialis muscle and close to the biceps tendon. Of course, it may not be found in 10% of the people it is present, but anyway, this should be mentioned, especially these that are related to the tendons of the two muscles, triceps and biceps. I think that you mentioned the bursae around the tendon of the triceps, so we can recall this knowledge here. There are also other bursae. These are listed here. I'm not going to pass through each of them. I'll stress on this one, the last one, which is extension down the neck of the radius. Saxiform recess is on the neck of the radius, protrusion of the capsule. The importance of this is mentioned, is important to alleviate the pressure there, to reduce the friction between structures. But these are also a cause of severe pain, invalidating. So the person may be disabled to continue his work or his sport. So this may turn into chronic, may chronify, may turn into habitual damage. So this bursitis is also one issue that should be discussed in anatomical course, because anatomy in this way serves clinic. The muscles here, you mentioned them, biceps. In fact, we can easily touch and find the attachment from the biceps here to the radial notch, to the radial tuberosity, and triceps. That's the most powerful structure here at the elbow joint attached to the olecranon posterior. These flexors, wrist flexors, are the muscles that originate from the medial condyle. These are that were called golfers muscles because these are quite often damaged in this spot. And there is extensors on the other side arising from the electroapical humerus, and these are the tennis elbow muscles, quite often damaged. When you see a tennis player with some bandage in the region of the elbow, you should know what happened. This is the biomechanics. Flexion and extension is the principal movement. You see the degrees, what extent. Of course, in females and children, the extension may be greater than this. It depends on the tendons and the process, how big is olecranon and the fossa for this. So these are arbitrary, the degrees, generally speaking. but hyperextension is also possible. Rotation, or as we say, pronation and supination, you know what does it mean, prone and supine position, is with extent of 75 to 90 degrees. Quite important movement, because this movement is always necessary when we perform some sophisticated work with our fingers. So we always use these passive movements. Pronation and supination are crucial for any sophisticated movement. When you start to work on the joint or on the region, we have to know what are the layers, how the structures are arranged. These are not randomly placed there, these are organized in a specific pattern. So we have first to pass through the venous layer, more superficially with the veins that are used to take samples. Pay attention that although we mentioned this structure here, spheric, basilic, and in medium cubital vein, these are not always seen. More often you see some variations. Aponeurotic is the next one, whereas the occipital aponeurosis, biceps, also attaches to the fascia, not only to the perineal tuberosity. And then the biceps brachii tendon below. Neurovascular bundle, here we should be very careful, because the three nerves, the major nerves that supply the forearm and the head are located here nearby. And also the major artery. From this artery, everything goes down all the blood, the brachialis artery. So we should be careful with this structure, most often medial to the biceps. We should be able to identify them by palpation. The muscles here, the next layer, supinator, brachialis muscle, and the tendon of the biceps. And most inferiorly, if you have to work on this, then you will find a humerus, radius, and downward. I don't know whether you use our plastics there today, but for today and tomorrow, but anyway, we have to know the flow of this cubital area. You see the elements, how these are arranged. We can draw cephalic, basilic, and median cubital vein, but it's not what you really find. Drawings have nothing to do with the real picture, so you should be able to identify structures when you dissect them. The best way to study is by dissection. So three variants, but these are much more of this region. The superficial venous layer is quite variable. Sometimes it's quite difficult to take blood samples if the technician is aware of this variation. The muscles, flexors of the forearm, extensors of the forearm, and biceps and brachialis. These are three groups of muscle forming three eminences located in this narrow area. So it's quite important to know this. The vessels is located in specific areas, and you should know where these vessels are located. The medial bundle, neurovascular bundle, is between biceps and pronator teres. Artery always goes actually with two veins on both sides, with the same name, and medianus internally. You should, if you make local anesthesia, you should know how to reach this median nerve. There are certain landmarks that you have to know. This fossa continues laterally with another bundle between brachialis and brachioradialis. Brachioradialis is muscle of the forearm, which is in the group of extensor, but actually it is never extensor, it is flexor. So between the brachialis and brachioradialis, we have the radial nerve and collateral arteries and recurrent artery that will make the so-called extensive network around the joint, arterial network, which is quite important to ensure blood supply of the forearm if we have some occlusion of the major artery. So you should also know these collateral branches forming the anastomosis here. Cubital fossa, we have the boundaries, brachioradialis, radial, and pronator teres medially, and the content, deep content, and the floor of this fossa is presented with two muscles, brachialis, biceps, tendon, and bicipito radial pulsar. There is one important bundle behind the medial epicondyle. It's one of the places, vulnerable places that we have to know and should be aware in case of trauma. This is the place where behind the medial epicondyle we can find the ulnar and the inferior collateral ulnar artery. In case of supracondylar fracture or fracture of the epicondyle, the ulnar node is damaged. So you can palpate the ulnar node there easily with your fingers. This is the funny bone, because it's also mnemonic how to remember this place, because if you hit the nerve there, you feel specific, quite pleasant or laughing feeling. Upward and downward along the course of the ulnar nerve. So this is the place where we can pay attention and study the relationship of the two arteries, the artery and the nerve, with the bone structures. So entrapment is also seen, although there is no trauma, there is no fracture, but sometimes muscles and ligaments that we discussed compress the nerve passing by and cause this cubital tunnel syndrome. So in this case, you see the ulnar nerve is here, and it can be compressed by the two heads of this flexor carpi ulnaris muscle. And also the bends are seen here, the bends of the medial collateral ligaments, that in case these are extensively organized, thicker, this can also compress the ulnar nerve. So this is entrapment of the ulnar nerve at the elbow. This is, you know, most often where is the place? Around the medial condyle. The medial nerve is important for the forearm, mostly. It is in the cubital fossa along the midline, close to the biceps. It bisects the cubital fossa, and it is deep to the bicipital neurosis. Bicipital neurosis is a landmark when you have to perform a kind of puncture or kind of cut here. This is just behind the skin. And passing through this aponeurosis is always dangerous for those that perform this manipulation. Laterally, it is associated with the bicep tendon. You can easily identify the bicep tendon. Medially with pronator teres. And deep to this medial nerve is the tendon of brachialis muscle. So, three structures, three tendons, powerful muscles that can compress the medial nerve. It leaves the fossa, the medial nerve, between the two heads of pronator teres. So the entrapment is here. So we need the ulnar tuberosity as a landmark here to identify. The nerve is close to this ulnar tuberosity, where the brachialis muscle is inserted. So we need this landmark where the brachialis muscle is attached to identify the position of medial nerve, and this is actually the position where the muscle, the nerve can be entrapped. You can place, to alleviate the pain, you can place the hand in neutral position. It's between pronation and supination position, intermediate to, this is the position where there is most base issues for the medial nerve. You see where this can be entrapped between the two heads of the pronator teres, and sometimes if you have extra bony structures, pico here with the tendon, this relation, this is in the above the medial epicondyle of the humerus. And radial nerve, the third nerve, is also here. On the other side of the biceps, it's the radial groove between the brachial and biceps. At the level of lateral epicondyle, it divides into superficial and deep branches. And anterior to the lateral condyle is the place where you can also make some test trying to identify the nerve, and this is a place where the nerve can be interrupted or damaged close to the epicondyle. So this is the radial tunnel syndrome, increased pressure of the radial nerve, which runs between muscles and bones. Muscles of the forearm, extensor muscles, originating from one and the same place, radial epicondyle. So most often it occurs during habitual movements, when you push, pull, twist, and grip with the hand, firmly. With the hands, in this case, the pressure is quite high on this radial nerve. Of course, direct trauma can be cause for damage, and other causes are given here, but these are quite rare for general practice, but maybe not for you, orthopedics. And finally, the supracondylar fractures, which are, I'm not sure about the rate of this, but these are quite often cited in the textbook as possible cause for damage to structures, that all the structures that we mentioned up to now. This is the most narrow point of the humerus, and this is weak point because here we have epiphysis and diaphysis meeting, and here in part of the period we have cartilage, growing cartilage, so this place is weak, this place of the humerus, like the surgical neck up in the upper part. Most frequently it is damaged when we have forward outstretched elbow on direct blow of humerus during some fight. The displaced fraction fragments, you see, this can damage. Because you saw the structures are tightly packed, nerves, vessels, and passing most of them anterior to the cubital fossa, so this can be damaged. When you repair a fracture, you should always test the blood vessel and nerve, whether this is not damaged. So when we can repair the bone, if the blood vessel and the nerve continue to be damaged, it will cause severe life-threatening condition. These are the structures that you have to bear in mind. Anteriorly, that can be damaged. Nerves, we discussed them, but I want to remind you, nerves, vessels. Don't forget the collaterals and recurrent arteries that form the anastomosis around the joint. And these examples how we can identify the structures, the three nerves that we discussed, using the landmarks of the cubital fossa. We need the medial epicondyle to find the medial nerve, but for this we need the biceps tendon, and you should be aware the brachial artery which is nearby should never introduce local anesthetic within the bloodstream. It can cause death, cardiac arrest. So this is biceps, the artery, and medial nerve. Ulnar nerve is easier to identify. It's always so long there with one collateral artery, so it's easy to identify behind the medial epicondyle. And this is the lateral epicondyle. We connect this with the biceps and divide it into three. And here you can see the medial part. This bisection indicates the position of the radial nerve. So we can make neural block and walk anesthesia. That's all I wanted to tell you.
I want to remind speakers that we have limited time for the presentation. We have 1 hour for this first session. Dr. Pellegrino will present us the risk and hand.
You can speak here, you can speak there. Doesn't matter. Well, it's more comfortable. Okay. This is laser and this one is forward and this one is backwards, yes.
Dear President, dear moderators, dear students, dear colleagues, it's a pleasure to be here. We could speak about hand anatomy for many hours, and I'm sure we all have better things to do. And this being a surgical anatomy course, I will just try to give you some important landmarks of the most important structures of the wrist and hand that will help you during the surgical exercises this afternoon. I think it can be more nice if it's an interactive lesson. So if you can lift up your sleeve, we're going to see together the different aspects of the wrist and the hand. So starting with the radiocarpal joint, the three landmarks that you can feel with your thumb is the styloid of the radius on the radial side, the styloid of the ulna on the ulnar side, and the Lister's tubercle in the middle. If you draw a line that goes through those 3 points, you have the proximal radiocarpal joint. Then, if you go on the other side, still on the dorsal side, but more distal, you have the basis of the metacarpal. You can feel the base of the first metacarpal still on the radial side, just at the distal end of the anatomical snuff box. Then you can feel in the middle the tubercle of the third metacarpal, and on the ulnar side you can feel the base of the fifth metacarpal. So if you draw a line that goes through these 3 points, you have the metacarpal phalangeal joint. In between those 2 lines, you have all the 8 carpal bones. Actually, you have 7 because the pisiform is on the volar side. It's not really a carpal bone. It's a sesamoid of the flexor calcaneus. I'm sure you know them, but going from the radial side to the ulnar side, on the distal row you have the trapezium, the trapezoid, the capitate, and the hamate, whereas on the proximal row you have the scaphoid, the lunate, and the triquetrum. On the dorsal side, you can recognize there is a soft spot in the middle of the wrist of this region. This is the head of the capitalis, so it will be this region here. If you push with your finger, you can feel there is a region that is a little bit more soft. On the other side, if you try to move around the crease of the wrist, you can feel the pisiform, that is this sesamoid bone on the flexor calcaneus. Still on the dorsal aspect of the wrist, you of course have all the extensor of the fingers. They go through the what we can see here, the extensor retinaculum. Its width is about 2 centimeters, and it's in correspondence between the radial styloid and the ulnar styloid. As you know, there are 6 compartments that we're going to see singularly. On the radial side, you have the first compartment that has the abductor pollicis longus and the extensor pollicis brevis. There are the 2 tendons that you have to free when you do the decurvent. You have the decurvent tenosynovitis. You open the first compartment. Moreover, this is an important compartment because it's the dorsal border of the anatomical snuff box. The anatomical snuff box, if you lift your finger, it's this hole you will have on the radial side, and it's an important landmark because its border are the first compartment on the dorsal, on the volar side, and the extensor pollicis longus on the dorsal side, and here you will feel the scaphoid. So sometimes if patients have pain here, you might suspect the scaphoid fractures. And it's also the place where you will have, we will see later on the approaches for surgical anatomy. The surgical approach for a trapeziectomy when you have right arthrosis is on this side. So these are the same things where you can see inside the anatomical snuff box, you have the scaphoid and the trapezium, and the radial artery that crosses in the floor of this anatomical snuff box. And this is a good landmark when you are doing the trapeziectomy to know the space between trapezium and scaphoid. Then, going toward radial, you have the second compartment that are the extensor carpi radialis longus and brevis. And the third compartment is the extensor pollicis longus. These are easy to find as they go on the radial and ulnar side of the tubercle of Lister. That is the little spot you can feel on this radius over here. The fourth compartment is extensor digitarum communis and the proper extensor of the index. The fifth is the proper extensor of the fifth finger, and on the sixth, the extensor carpi ulnaris. It's very important to remember that the extensor, the extrinsic extensor, as already said by the previous speaker, that originate from the lateral epicondyles, their main function is to extend the metacarpal phalangeal joint, whereas the interphalangeal joint are extended by the intrinsic muscle, interossei and lumbricalis. So if you have a patient with a wound on the dorsal of the hand, and you ask him to move and he does that, it doesn't mean that he has a lesion, he has no lesion. This is not because the extensor are moving, it's because his intrinsic muscles are moving. On the other side of the hand, on the volar aspect, you can feel the pisiform and the hamate on the ulnar side, and the scaphoid and tubercle of the trapezium on the radial side. In between those 2 points, you have the flexor retinaculum, and that we will see later on with the surgical approaches for the carpal tunnel release. And at this level, with the median nerve under the flexor retinaculum, you will have all the superficial and profundus flexor tendons. The superficial will insert on the middle phalanx and are the one who will allow to do this kind of movement, whereas the profundus will insert on the distal phalanx and can selectively flex the distal interphalangeal joints. Still on the volar aspect of the hand, you can feel very well the flexor radialis carpi radialis on the radial side. It's also an important landmark for the wrist surgery. It's very easy to feel, and on its radial side, you will have the radial artery that you can easily feel. Putting your 2 fingers, it's when you feel the pulse of the radial artery. On the other side, you have the ulnar carpi radialis, and still radially to the ulnar carpi radialis, you have flexor carpi ulnaris, you have the ulnar nerve and ulnar artery that will go to the Guyan canal. That is a frequent localization of compression of the ulnar nerve. Then in 80% of the population, there is palmaris longus. To know if you have a palmaris longus, that is not represented in this figure, but is a tendon that will insert on the aponeurosis of the hand at this level. It has no real function, but this is the reason why it is used to make it is used as a tendon, a bank tendon when you have to make some tendinous reconstruction. To check if you have it, you can join your first and fifth finger, and you might feel something in the middle of your wrist. Finally, the muscles of the hand. You have the intrinsic muscle that are the muscle of the thenar, eminence thenar. You can put your index finger on the lateral side of the finger, and if you go through, like in this picture, you can see that from radial to ulnar you have the 4 muscles that are opponent pollicis, abductor brevis, flexor pollicis brevis, and abductor pollicis. Same thing on the other side. You have the hypothenar muscles. If you put your ring finger on the border of the 5th metacarpal, then you go along with your finger, you can recognize the abductor digiti minimi, the flexor digiti minimi, and the opponent's digiti minimi. So, of course, these are only basics of the hand anatomy, but are the good and important landmarks to know for the next lesson I will have later about the surgical approach to the hand. Thank you.
Един микрофон. Да, и за него. За него къде е момчето с микрофоните, че сега ще ми кажа.
Sì.
Next speaker is must search our approach for shoulder arthropathy. Speaks in Italian with the translation in English.
So the presentation will be in Bulgarian language because I will translate so you will get the one. Всички. Съжаление, моята презентация ще бъде на български. Моя колега професор Ставрев ще помогне в превода. Хирургични достъпи до рамената стават при ендопротезиране. Surgical approaches to the shoulder joint during shoulder arthroplasty. Обръщам внимание, че това е при ендопротезиране, а не при всички достъпи до рамената става. This is only for endoprosthetic replacement of the shoulder joint, and these are not all the approaches. Целта на настоящото ми съобщение е да представя моя опит при прилагане на различни анатомични ориентири и достъпи до рамената става при ендопротезиране. The point of my presentation is to present the most common approaches to the shoulder joint when doing endoprosthetic replacement. Периодът на проследяване обхваща последните 5 години. За този период в катедрата по ортопедия и травматология на Медицинския университет в Варна в Света Ана са извършени 35 алопластики на рамената става след фрактури на фракционалния хумерус. So the period takes 5 years. For this period of 5 years, the Department of Orthopedic and Traumatology Surgery at the Medical University of Varna have done 35 endoprosthetic replacement of the shoulder joints. Пациенти са възрастова група на 70 години, като от тях 30 са жени и 5 са мъже. Бяха имплантирани 32 хемии протези и 3 допорси. So, all the patients were above 70 years of age. Out of them, 30 were women and only 5 were men. We implanted 32 hemi prostheses and 3 bipolar prostheses. При ендопротезирането сме използвали различни достъпи до рамената става. За обработка на резултатите направихте артропластика и използвах методът на Constant Shoulder Score, с анкетна карта.
When doing the prosthetic replacement, we use different approaches on the shoulder joint. In order to process data, we use the constant shoulder score.
В нея се проследява състоянието на пациента на 4-та седмица след интервенцията и следва се нивото на болка, на активност и движение в рамото.
By using the constant shoulder score, we investigated our patients on the 4 weeks after surgery. We measured the level of pain, and we also measured the range of motion in the shoulder.
Всеки един от показателите носи съответната оценка, в резултат на която се обобщава състоянието на пациента. То варира от лошо до отлично.
So all these criteria describe the patient, his status. And the status of the patient varies between bad to excellent status.
Друг метод, използван за статистическа обработка на резултатите, е визуална аналогова скала за болката.
So the other method that we use to estimate the condition of our patients was the visual analog scale.
При ендопротезирането на пациенти в клиниката по ортопедия и травматология на болница Света Анна Албания са използвали няколко различни достъпа до рамената става.
When doing the endoprosthetic replacement of the shoulder, we used several different approaches to the shoulder joint.
Преден делтоидопекторален достъп.
Anterior deltoidal approach.
Прави се кожен разрез по протежение на sulcus deltoidopectoralis.
The skin incision is made along sulcus deltopectoralis.
След прерязване на кожата и подкожието се открива връзката между мускулус deltoideus и мускулус pectoralis major, запълнена с масна тъкан. В нея върху предния ръб на мускулус deltoideus движи вена цефалика.
So after cutting the skin in the subcutaneous tissue, we find the deltopectoral sulcus, then we divide the musculus deltoideus from musculus pectoralis major, and we see the cephalic vein, which is on the medial margin of the muscle.
Друг ориентир за границата между двата мускула е разликата в посоката на мускулите и влакна. Тези на мускулус deltoideus са разположени отдолу нагоре, докато тези на pectoralis major са разположени напречно.
So other thing that we notice in order to identify the sulcus, this is the direction of the muscle fibers. The deltoid fibers are going from proximally to distally, and the pectoralis major fibers are going in a transverse manner.
Вена цефалика може да бъде характерирана заедно с делтоидния мускул навън и да се иритира. При проникването в дълбочина се разкрива сухожилието на късата глава на мускулус biceps brachii.
The cephalic vein can be either retracted laterally or it can be ligated. When we go deeper, we can see the tendon of the long head of the biceps muscle.
Това сухожилие може да бъде и картирано или прерязано и след това отново прикачено.
This tendon can be either retracted or cut, and then when finishing the surgery, reinserted.
Открива се мускулус subscapularis, който ако е отделен заедно с малкия туперко при фрактура, се е картира медиално, а ако не, се прерязва на сантиметър и половина от залатното място.
Then we reach musculus subscapularis. If it is fractured together with the lesser tubercle, it is retracted medially. If it is not fractured, the lesser tubercle, then we cut it about 1 centimeter medially to give the attachment point.
Преден латерален трансделтоиден достъп. Преден латерален трансделтоиден достъп.
Anterolateral transdeltoid approach.
Прави се кожен разрез латерално от делтоидо-пекторалната бръзда.
We do the skin incision laterally to the deltopectoral sulcus.
Ето ги ориентирите. Открива се нервус мускулус cutaneus и се картира заедно с корекопедиалния мускул.
We find nervous muscle tunnels and very attractive, together with the coracoid muscle.
Между влакната на мускус делтоидеус се прояви тъпо, за да не се наруши инервацията им с последваща атрофия.
With the blunt dissection of the fibers of the deltoid muscle in order not to injure this muscle in the lower body.
Следващите стъпки при този достъп са идентични с тези при предния делтоидопекторален.
Next steps of this approach are identical to the steps that we do when doing the deltopectoral approach.
Горно-латерален достъп.
Anterosuberer approach.
Кожният разрез е 10-12 см, може да се извърши близо до началото или близо до края на латералния кръг на акромиона или в латерална посока.
So the incision is 10 to 12 centimeters long and it can be done near to the beginning or near to the end of the lateral margin of the acromion.
Следвайки подкожната дисекция се отделят предните и средните делтоидни мускулни връзки, които се намират срещу латералния край на акромиона, използвайки за обредна дисекция.
Following the skin incision, we find the anterior and median deltoid muscle ties, which are opposite to the lateral end of the acromion.
Горно-латералния достъп, при него дисекцията започва на ниво акромиопарикуларна става, 5-7 см след върха на акромиона и продължава паралело-латерално надолу по делтоидния мускул.
The next approach is the superolateral approach. The section begins at the level of the acromioclavicular joint, 5 to 7 millimeters after the tip of the acromion, and goes along laterally and down, following the deltoid muscle.
Не трябва да продължава повече от 4 см от външната част на делтоидния мускул, за да може да се предпази нервус акселарис, който се намира по гръдката на суpraклавикуларната бурса.
We mustn't go distally more than 4 centimeters along this approach because we can injure the axillary nerve, which is underneath the fold of the supracranial bursa.
Когато суpraклавиалната бурса е видима, внимателно продълговато издърпване по дължина на крайника позволява да бъде поставен ретрактор в суpraклавиалното пространство.
When we see the supracranial bursa, we carefully pull the upper extremity and also carefully apply the retractors.
След това предната част на делтоида се отпуска от акромиалната инсерция до акромиопарикуларната става.
After that, we can finish the pulling, and the mid part of the deltoid is loose up to the acromion insertion of the acromioclavicular joint.
Отделянето на делтоида от предната част на акромиона може да включи малка част от коста, което да улесни възпадряването и да предпази делтоидния мускул.
When we separate the deltoid muscle from the anterior part of the acromion, we can take it away from the small part of the acromion, and this, by the end, enables easy restructuring of the muscle back to the acromion.
След това крайникът се завърта в външно положение и главата се премества предно, за да се извърши правилно позициониране.
Then we do external rotation of the extremity, and the head is positioned in the other part.
Ако бицепсът е все още видим, трябва да се извърши тенотомия или тенотеза.
If the biceps is still visible, we must do either tenotomy or tenodesis of the tendon of this muscle.
Musculus substacularis, musculus teres minor и musculus infraspinatus се задържат, когато са видими.
The subscapularis, the teres minor and the infraspinatus muscle are retained until they are visible.
Може да се извърши частично отделение на мускул субстапуларис, когато е трудно да се получи по-голямо разместване на хумералната глава.
We can do a partial tenotomy of the subscapularis muscle if we cannot shift anteriorly the humeral cap.
И най-щадящия и за мен най-любим латерален трансделтоиден достъп.
So the most sparing and my favorite approach, this is the lateral transdeltoid approach.
При този достъп основно трябва да се съобразява хода на nervus ancillaris.
When doing this approach, you must think about nervus ancillaris.
Той преминава отзад напред, напречно на мускулните влакна на около 5 см от акромиокорвикуларната става и началото на делтоидния мускул.
He is going transversely around 5 cm from the acromioclavicular joint.
Поради тази причина надлъжното разделение на мускулните влакна не трябва да надминава 3-4 см от началото на мускула.
Because of the axillary nerve, the split of the deltoid muscle fibers must be more than 3, maximum 4 cm distally to the joint.
Този достъп е показан при определени фрактури, определени случаи на артроза и може да бъде извършен само от опитен хирург.
This approach is recommended in certain fracture and certain arthrotic cases, but must be performed by very, very experienced surgeons because of the axillary nerve potential damage.
В заключение, използването на определен достъп до рамената става при рано на ендопротезиране зависи от няколко фактора.
When doing approaches to the shoulder joint, several factors are very important.
На първо място от вида на използваната ендопротеза, моноблок, двукомпонентна или ревърс.
The first phase, this is the type of the prosthesis. Monoblock prosthesis, bicompartmental prosthesis or reverse prosthesis.
От съществено значение са опита и предпочитанията на хирурга.
Very important is the experience of the surgeon and his preferences.
И не на последно място от значение са наличната база и операционното оборудване.
And very important are the surgical instruments and the operating theater equipment.
Основните достъпи до рамената става, които ние най-често използваме при ендопротезиране са делтоидо-пекторалния и предно-латералния трансделтоиден достъп. В последно време по-често използваме и латералния трансделтоиден достъп.
The main approaches that we do when we do shoulder endoprostatic replacement. This is the deltopectoral approach, the anterolateral approach, and lately we are doing transdeltoid approach.
Thank you very much. Thank you, Professor Steyer.
The next speaker is Dr. Kirill Tilovic. Surgical approach to the elbow, Dr. Tilovic.
Can you tell me which presentation? What's the name? Yes. This one? To the elbow.
From the shoulder to the waist, there is the elbow. That is a complex joint that doesn't like surgical treatment and the traumatic injury. So, the principle general of this kind of surgery, the rigorous adherence to the principle for good surgical technique is absolutely essential for the elbow surgery. The most appropriate surgical approach depends on the specific treatment goal, the nature of the lesion, and the extension of the pathology. The choice of surgical approach should be based on these few concepts. The flexibility, that is the most important, should allow the extension of the extrosome. Adequate for a good visualization of the lesion. The safety, especially from the nerve. The respect, the preservation, or the respect of the anatomy of the joint. The physiological plane, the respect of physiological plane, that extend along the fashion that's sometimes spread overall. The hemostasis that is accurate after release the tourniquet, and the closure, because we have the necessity of modifying the specific feature of the case. We can identify four topographic approaches that present the workhorse for the surgical exposure of the elbow joint. The transolecranic approach with the proximal extension, the trapezium, the lateral approach according to Kaplan or Cocker, an anterolateral approach to the capitellum and the biceps tuberosity, the anteromedial approach that is a challenging and not frequently employed because of the vulnerability of the brachial artery and the median nerve. But it's the most important surgical approach because it's the left to expose the tuberculous sublimity. And after the last, the medial approach, the orthopedics, that is a sensible medial or over-the-top approach. The posterior approach is the door of the elbow joint. The indication are the ankylosis joint and overall the treatment of the supracondylar fracture of the humerus. This approach left a wide exposure of the articular surface, the high stability of the osteosynthesis for an immediate and intensive rehabilitation program. With the patient in bronchus-born or lateral position, the elbow is in a flexion of 90 degrees with forearm free. The position of the tourniquet at the root of the arm, and we perform a skin incision of about 20 centimeters on the tip of the olecranon. So we expose the triple tendon and immediately we identify the ulnar nerve and perform a wide neurolysis until the first motor branch. The preparation of the housing for a cannulated intramedullary screw for the synthesis of the olecranon, identification of the pair area, that is a region within the articular surface that the void of cartilage and is commonly identified by the narrowest part of the greater sigmoid notch. We perform a chevron osteotomy of the olecranon, the proximal release and overture of the olecranon with the triceps tendon. So we perform an anatomical reduction of fracture, the osteosynthesis of the diacondylar fracture, and the osteosynthesis of the epiphyseal massif with the metaphysis of the humerus. Overturing the olecranon and the conneus muscle, when we have just prepared before, osteosynthesis of the olecranon with cannulated screw or tension band or plate according to the preference of the surgeon and of the bone quality. Very important, and in the operative room report, we should clearly describe how the ulnar nerve has been managed and its location at the end of the operation. The flexibility of this approach is characterized by a proximal extension in the integration with the triceps elevating approach according to Brian Murray. The tricerson led a positioning of the long implants for the treatment of the metaphysis future, the metaphysis fracture, avoiding the damage of the radial nerve that is elevated and blocked with triceps intermuscular septum and brachialis muscle. What's that? So this is the block with the triceps, intermuscular septum, and the brachialis muscle. Without so we can avoid the neck, the radial nerve. The other approach is the lateral approach. With we have two different intervals, the Kaplan and the Cocker. One is anterior, the other is posterior on the lateral side of the elbow. This led the treatment of the isolated local lateral epicondyle fracture, lateral epicondyle avulsion fracture, coronal shell fracture of the radial head, fracture of the coronoid, and the prosthesis of radial capitarium. With the patient superior position, flexion of the elbow at an 80-degree Z, tourniquet at the root of the arrow. Skin incision is centered on the lateral epiconoid, about 6-8 centimeters. Each is the deep fascia in line with the skin incision, and rise a flap to expose the muscular blade. We can extend proximally along the lateral supracondylar ridge until the radial nerve, about 10 centimeters from the tip of the leg. The distal extension is in line of the radial head, along with the common extensor digitalis muscles. The radial nerve runs because the radial nerve runs close to the radial head and the neck. It divides in two branches, the superficial and the deep at the level of the radial head. When you operate on the radial head, sometimes there is associated injury of the lateral collateral ligament and the common extensor digitorum and the wrist muscle origin. Along with this damage, there is a rate in the fascia that can be opened and extended distally. This usually lies in the interval between the extensor carpi radialis brevis and extensor common digitorum, that is the Kaplan interval. This interval can also be identified elevating the origin of the extensor carpi radialis brevis from the supracondylar ridge of the distal humerus and the brachialis from the anterior humerus. Elevating this muscle is necessary to expose the coronoid from the lateral side, the tip of the coronoid from the lateral side. The Cocker interval is the interval between anconeus and extensor carpi ulnaris and is relatively more posterior and thus risk injuring the lateral collateral ligament complex. For the preserve the integrity of the radial nerve, fully pronating of the forearm protect the posterior interosseous nerve, that is a motor branch, by moving it away from the operative field. Beware of the incision of the capsule to anteriorly because the radial nerve lies over the front of the anterolateral position of the elbow capsule, and the fixation of the distal annular ligament because the nip lying within the supinator muscle is at risk. The deep surgery, the dissection, prevents the annular ligaments is divided in a line with muscle interval. So we can follow the neck of the radius. The medial approach is the hot case of the top, is the most anterior for the medial approach and provides a good access to the tip of the coronoid process and the wall of the anterior joint. The interval that splits the flexor pronator group and elevates the part are the pronator teres, flexor lunaris carpi, and palmaris longus. The access to the medial surface of the coronoid is limited, and there is also a poor access to the base of the coronoid sac. For the access for medial surface, we can use the interval where the ulnar nerve lies between the head of flexor carpi ulnaris, and for the access, for the approach to the base, we consider elevating the anterior flexor pronator group from the posterior to anterior, the Taylor and Sackham and Sham approach. After there is the very medial approach, the other approach is the medial approach, in which the skin incision can either be posterior with a medial skin flap of direct medial, taking care to protect the branch of the medial arterial antebrachial cutaneous nerve, which travels more anteriorly. The ulnar nerve should be identified and protected with the neurobasis. Generally, it is unroughed for 6 cm proximal and distal. Consider anterior subcutaneous transposition if you think this will keep the nerve safe. Follow the ulnar nerve distally as it goes under the fascia between the two heads of the flexor carpi ulnaris. Incise it and protect the first motor branch running to the humeral part of the flexor ulnaris carpi. We have identified the anterior ridge of the flexor pronator group over the top of the brachialis and near to where the medial nerve and the brachial artery lie. With the ulnar nerve identified posteriorly, the flexor pronator group muscle can be split in the medial to get better access to the anterior medial part of the coronoid. Elevated palmaris longus, flexor carpi radialis, and pronator teres origin capsule medial epicondyle. Extend this excision proximally by extraperiosteal periostal dissection to the brachialis muscle and the floor, the flexor pronator group of the medial supracondylar ridge at the distal humor, and we can see the anterior capsule. Using a blunt retractor, the exposure can be improved across the anterior elbow joint. We can split the pronator group more distally for better exposure to the medial part of the coronoid. For instance, a long plate fixation if it is planned. This is the flexibility of the approach. So the elbow joint surface can be exposed with an anterior capsulotomy. The anterolateral approach prevents the indication is the bicipital tuberosity, the attachment of the biceps tendon, or excision of the neoplasia on the radial neck or the radial metastasis. Patient in supine position to indicate the root of the arm, forming complete connection to protect the hip. The curved incision over the anterior surface of the ear we perform, starting 5 cm above the crease of the lateral side of the biceps. Curve the incision over the front of the elbow until the medial border of the brachioradialis muscle. Incise the fascia under the subcutaneous tissue, identify protecting interosseous branch of the radial. and the lateral margin of the brachialis muscle. Carefully follow this branch into supinated muscle. Split this fascia and ligate the recurrent artery. Further deep dissection expose the bicipital tuberosity of the radius or the radial. The anteromedial approach. The indication is the reduction of osteosynthesis of the coronoid process. The preparation prevents the patient in supine position with forearm supinated and the elbow extended. And the step incision start 2 cm proximal to the elbow flexion crease, curving across the elbow crease, extending distally along the radial border of the forearm approximately 4 cm distal to the flexion crease. The main superficial veins were identified and protected with non-ligated. The approach runs from the radial proximal side to the lateral side on the anterior surface of the head, which avoid cutting the cephalic vein, basilic vein, and the median ictal vein. Careful blunt subcutaneous dissection is performed to expose the medial antebrachial cutaneous nerve, which have to protect it and retract it medially. The deep fascia, the biceps and bicipital aponeurosis is unroved, and as well the distal part of the brachioradialis and the pronator teres muscle. Transverse split of the bicipital aponeurosis provide an excellent exposure of the proximal brachial artery, vein, and medial nerve. The brachial artery, biceps tendon, and the brachioradialis muscle were retracted laterally, whereas the medial nerve and the pronator teres were retracted medially. Providing the best exposure, this exposition will provide the best exposure of the brachial muscle. A longitudinal muscle split and its retraction provides a good visualization of the capsule, ulnar coronoid fraction, and the base of the coronoidal process. Thank you for your attention.
Thank you. The next speaker, I invite Dr. Campo for surgical approaches to the forearm.
Good morning, everyone, dear colleagues, Mr. Chairman. I am orthopedic surgeon from the University Hospital of Pisa. Thanks for the invitation, especially Professor Rosa, my mentor and teacher during my resident period. I will talk about the surgical approach before. So I will describe you the anterior approach, the posterolateral approach, and finally the direct approach to the ulna. I will start with the anterior approach. The indications are osteosynthesis of fracture, treatment of fractional unions with the bone grafting or fixation, radial osteotomy, biopsy and treatment of bone tumors, removal of sequestra in chronic osteomyelitis, anterior exposure of the bicipital tuberosity. Place the patient spine on the surgical bed with the arm on the operating table. So, place tourniquet and inflate it, but do not let the blood flow completely before inflating, because if it remains a little bit of blood, the vascular structure are easier to identify. So, finally, supinate the forearm. The landmarks are the proximal area, the bicep tendon which crosses the front of the ulnar joint, and in distal point, the radial style process. The brachioradialis muscle is a part of the moving body comprising the brachioradialis and the sensor carpi radialis brevis and the longus. The internervous plane distally lies between the brachioradialis muscles and the flexor carpi radialis muscle. Proximally lies between the brachioradialis muscles and the pronator teres muscles. Make the incision from the anterior flexor piece of the elbow, just lateral to the bicep tendon, down to the sternal process of the radius. So, in this way, we divide the forearm into three parts: proximal, middle, and distal third, as you see in this picture. Cut the fascia in line with the skin incision, identify the middle border of brachioradialis, and develop a plane between it and the flexor carpi radialis distal. At the level of the elbow, the brachioradialis extends almost halfway across the forearm. Identifying this section, identify the superficial radial nerve running on the underspace of the brachioradialis and the moving with it. This muscle receives a number of arterial branches. The arterial branches arising from the lateral side of the radial artery are identified by a sleeping finger under them, lateral to artery. It is important to get this recurrent tissue vessels to make it easier to move the brachioradialis laterally. In the proximal third of the radius we find the supinator muscle, to which the posterior interosseous nerve. This is a most important factor. In fact, in this approach, a strong retraction of this nerve causes a neuroapraxia, so move it carefully. So displace it laterally and posteriorly, away from the surgical area. Follow supinate the forearm, exposing the insertion of the supinator muscle into the anterior aspect of the radius. Next, make incision the supinator muscles along the line of its broad insertion, and continue superiosteal dissection laterally, detaching the muscles from the body. We move to middle third, that's covered by pronator teres and flexor distal superficialis muscles. To reach the anterior surface of the bone, pronate the arm so that the insertion of the pronator teres onto the lateral aspect to the radius is exposed. Detach this insertion from the bone and strip the muscle off linearly. This maneuver detaches the origin of the flexor digitorum superficialis from the anterior aspect of the radius as well. In the distal third, we find two muscles, the flexor pollicis longus and the pronator quadratus, arising from the anterior aspect of the distal third of the radius. To reach bone, partially supinate the forearm and make incision the periosteum of the lateral aspect of the radius lateral to the pronator quadratus and the flexor pollicis longus. Then continue the dissection distally, retracting the two muscles medially and lifting them of the radius. The main dangers are nerves and vessels, starting with the nerves. In particular, the posterior interosseous nerve. In this picture, we see in this picture, we see the posterior interosseous nerve that entering in the process arcade and then into supinator muscles. And so we see the superficial radial nerve run down the forearm under the brachioradialis muscles. The radial artery runs down the middle of the forearm under the brachiolateral muscles. It's a vulnerable factor during mobilization of the brachiolaterals, as the artery goes to the medial side of the biceps tendon. And the recurrent radial arteries. These factors that they consist in two groups, anterior and posterior, which go in front of and behind the superficial radial nerve, before entering the brachiolateral muscles. I will continue with the posterolateral approach. The indications are almost the same as Arias' approach. Place the patient supine on the surgical bed with the arm over on operating table, pronating the patient's arm to expose the extensor compartment of the forearm, or put the patient's arm across the chest and supinate the forearm to expose its extensor compartment. The international plane proximally lies between the extensor carpi brevis muscles and the extensor digitorum communis muscles. Distally lies between the extensor carpi brevis muscles and the extensor pollicis longus muscles. The landmarks are lateral epicondyle, just lateral to the olecranon process on the distal humerus, and the listed propofol is about a third of the way across the dorsum of the wrist from the styloid process of the radius. So, make a straight or curved incision extending from a point anterior to the lateral epicondyle of the humerus to a point just distal to the ulnar side of the listed tubercle at the wrist. In this approach, normally only part of this incision is required for any operation. In case of fracture, center incision only over the fracture site. So, in surgical dissection, identify the space between the extensor carpi radialis brevis and the extensor digitorum communis. This space is clearly evident distally, where the abductor pollicis longus and the extensor pollicis brevis emerge from between the two muscles. Proximally, the extensor carpi radialis brevis and the extensor digitorum communis share a common aponeurosis. So, continue the dissection proximally, separating the two muscles to reveal the upper third of the shaft of the radius, which is covered by the enveloping supinator muscle. When identify the posterior interosseous nerves and the preservatives secondly, found supinate the arm to bring the anterior surface of the radius into view. Detach the dissection of the supinator muscle from the anterior aspect of the radius, shifting it from the bone exposing to the proximal third of the shaft of radius. We move the middle third. We find the two muscles, the abductor pollicis longus and the extensor pollicis brevis, that cover this approach as they cross the dorsal aspect of the radius before adding distally radially across the middle third of the radius. To retract them off the bone, make an incision along the superior and inferior borders, and the distal third separating the extensor carpi radialis brevis from the extensor pollicis longus, already as read directly onto the lateral border of the radius. The danger is the posterior interosseous nerve. The main danger is this structure. And finally, we talk the direct approach to the ulna. The indication are the same of the previous approach, except for the ulnar lengthening and the ulnar shortening. Place the patient supine on the operating table with the arm placed across the chest to expose the subcutaneous border of the ulna. Drop blood by elevating the limb for 3 to 5 minutes or using a soft rubber bandage and then a tourniquet. The internecus plane lies between the extensor carpulnaris muscle, which is supplied by posterior interosseous nerve, and the flexor carpulnaris muscles, which supplied by the ulnar nerve. Landmark is a subcutaneous border of the ulna. So make a linear longitudinal incision over the subcutaneous border of the ulna. The length of incision depends on the amount of bone that is to exposed. Cut the fascia along the same line as the skin incision and continue the section down to the subcutaneous border of the ulna. Even though the bone feels subcutaneous in its middle third, the fibers of the extensor calcaneus always have to divide to reach the bone. Make incision the periosteum over the ulnar longitudinally and continue the section around the bone in a superiosteal plane to reveal either a flexor or extensor aspect of the bone. In the proximal point of the ulna, part of the insertion of the triceps tendon will need to be attached to gain access to bone. The danger are nerves and vessels. The ulnar nerve which travels down the forearm and the flexor calcaneus lies on the flexor digitory profundus. If the dissection strays into substance of the muscles or wiggle, the nerve may be damaged. So it's important to recognize the nerve and preserve it in its approach. And then finally, the ulnar artery runs down the forearm with the ulnar nerve, lying on its lateral side. It also vulnerable fracture when the section of flexor calcaneus is not carried out superiorly. Thank you for the attention.
So, next speaker, most surgical approach to distal radius in case of community metaphysical fracture. Dr. Stefano.
Colleagues, the first anatomical course was long ago in the 2011 here in Varna, and it was the beginning of our meetings. Now we speak about the most useful surgical approaches to the distal radius in cases of fractures, and special the community metaphyseal fractures. You see the sculpture of the boy in Davos. It's the most often injury mechanism of the distal radius. There are palmar approaches, and most often used approach is the modified Henry approach. It's suitable for the most fractures of the distal radius. There is also ulnar palmar approach, and it's special for isolated facet fractures, and ulnar palmar approach is in this case more useful. It can be extensional approach, ulnar palmar, for the compression of the carpal the classical Henry approach goes between the brachioradialis and the radial artery, and the modification is between the flexor carpi radialis, you see the white arrow, and the radial artery. Ulnar to the radial artery is the modification of the Henry approach. Before we make the incision, you palpate the flexor carpi radialis tendon and make the incision on his radial side. During this approach, there is a risk for the radial artery and for the palmar cutaneous branch of the median nerve. It must be identified during the incision in the subcutaneous and be safe. You see the flexor carpi radialis tendon, and along his radial border, we make an incision, open the seat and retract the tendon ulnar. Repeat incision between the flexor pollicis longus and the radial artery. Here is the flexor pollicis longus. And after that, a blood dissection with the finger to retract the muscle, flexor pollicis longus muscle daily, and this increase the space and expose the pronator quadratus muscle. The pronator quadratus muscle have to be incised in the horizontal plane on the border of the radius, but not in the space of the articulation. And then radially, on the radial border, proximally, and when you distract the pronator quadratus, you see the volar aspect of the radius, for example, the fracture of the radius. You see the elevated after the L-sharp incision, and you make the horizontal incision of the pronator on the so-called water-shaped line. This is a few millimeters proximal of the joint line. It's important because if you cut distally, you have to, you can disturb the perfusion of the part of the distal subchondral bone, and it is very important for healing of the comminuted fractures of the radius. The wound closure, you reconstruct the pronator quadratus over the plate, and you became a white tissue covering with the implant. The ulnar palmar approach, the plane is between the ulnar artery and nerve on one side and flexor tendons on the other side. The incision is parallel to the ulna and can be extended along the worst case and distally in the palmar region. between the ulnar artery and the flexor tendons. And after the retraction of the flexor tendons, you see the pronator quadratus. The pronator quadratus is incised as long as you need for a visualization of the distal part of the radius. It can be extended distally, this approach, if you need to decompress the carpal tunnel, or in high energy trauma, you became a good access to the radiocarpal structures during this extended approach. The dorsal approach. The dorsal approach is not so often used in the traumatic cases of the distal radius, but is a very, very good possibility to achieve the fractures and make the good osteosynthesis. There are different approaches, dorsal approaches, and between the different extensor compartments, but most often it is used the P variant through the third extensor compartment. But you can use combination of all these approaches. The dorsal approach is based on the common theory of Ricci-Regazzoni for the tricolumn biomechanical acception of the distal radiocarpal joint. You see here the incision. And if you need to approach the intermediate column, you open the third compartment on the line of the extensor pollicis longus tendon in the extensor retinaculum. Extend the incision proximally and the extensor retinaculum will open distally, but not the all retinaculum. The distal part will be preserved for the anatomical guiding of the tendon. But you can open distally the whole retinaculum if you need for a reduction or stabilization of the fracture. Then you elevate, mobilizing and elevating the flexor pollicis longus tendon, and you make a superior solid elevation of the fourth compartment. It means ulnari from the incision, superior stanley, the compartment itself is intact. Arthrotomy in this case of approach is optional. You can cut the capsule transversally on with the line of the distal radial articular surface. It's not a danger to damage the osseous perfusion of the distal radius with this cut compared with the radial capsulotomy. Here is not a risk. But through this cut you can see the very important fragments of the distal, four-part distal radius fracture, the dichroic injuries, and the associated carpal ligamentary injuries. To the lateral column, there are two options to come to the lateral column of the distal radius. Extra-articular approach is for extra-articular and simple articular fractures, and is with elevating of the second extensor compartment for intra-articular fractures of the scaphoid facet or ulnar fossa. You see the incision of the fascia in the extra-articular dorsal approach between the extensor compartments 1 and 2. 1 and 2. Here. Through this incision, you can not expose the articular surface. The first step is to identify and protect the sensory branch of the radial nerve in this ramus superficialis nerve radialis. Sometimes you have to release the brachyradialis tendon for the reduction of the fracture. The incision follows through the first compartment and proximally of the level of musculotendinous transition, release the tip of the radial stellate distally, and the tendons of the first extensor compartment are mobilized, released and mobilized. And then you have make a superior stump elevation of the second compartment. And you can see now the tip of the radial stellate. This other option to approach to the lateral column of the distal radius. First, you identify the listener tubercle, and again, partially elevate the second compartment. The extensor pollicis longus can be retracted on the ulnar side, and the second compartment with his contents is superior style with sharp decision elevated from the distal radius. You see the sharp decision of the second compartment is seen here, and the incision, deep incision of the periosteum of the distal radius. Then you make the so-called Berger capsulotomy. Is a capsulotomy with a flap proximal from the joint level, and through this approach you can make plate osteosynthesis of the radial column. You can distract the extensor pollicis longus, both sides, ulnar or radial, in the cases of different types of fractures. You see here the capsular incision, big enough. first and second compartments not tight closing. And if a plate has been applied, this incision flap from the dorsal retinaculum must be positioned under the tendon over the plate. In the direct lateral approach to the distal radius, extra-articular simple and intra-articular simple fractures. The incision is along the mid-axis of the lateral side of the distal radius. You have to find and protect the superficial branch of nervus radialis. It has almost 2 anatomical variations, and in case what variation you find, you can lift the nervus dorsally, or with separation technique, dorsally and volally, the branches of this nerve. The deep incision of the retinaculum is on the first extensor compartment, abductor pollicis longus and extensor pollicis brevis. Sometimes is in separate compartment, this tendon, and then you retract the tendons dorsally and make a periostal incision to partially detach the brachioradialis muscle and the pronator quadratus superiostali volari. After the plate osteosynthesis, you reattach the pronator quadratus through the course of the plate. If you need bone grafting with dorsally comminuted fractures, metaphyseal fractures, you can do it through this approach. And there are some minimal invasive approaches. There are 3 different types. Single longitudinal palmar incision, double K incision, and double position 2. There are good results if you can make a good close reposition of the fracture. You can use these incisions, the minimal invasive incisions. The longitudinal single palmar incision, you see, is over the flexor cardioradialis tendon, 3 centimeter skin and fascial incision, and flexor pollicis longus and radial vessels are separate. It's the same like the Henry approach, and you locate the watershed line. It's a few millimeters proximal from the joint line, and when you use the elasticity of the skin, you can place a locking plate for distal radius and place then the screws through a little proximal port on the end of the plate. The incision, the distal incision is transversal, and the proximal incision for the fixing the plate screws are longitudinal. You can fix the reduction of the fracture with Kirchner wires during the stabilization with 2 or 4 mm LP. 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 in subpronator quadratus position. And the last mini-invasive approach is with two longitudinal incisions. There are the same steps during the fixation with distal radius grade. You have to remember the reposition, close reposition must be, you can be able to make a good reposition before using this approach. You see a double site approach, a standard Henry approach, and plating, a dorsal intermediate approach, and plating with B-plate, and the reduction is holding with the extensor X-fix, extensor fixation. You see the end photo and the end result. Thank you for the attention.
Thank you very much. Last presentation of the section, surgical approach to the end, trophobia.
Surgical approach to the end. So, hello again. I will start giving some general principles about surgical approaches to the end, and then I will describe the most common end surgeries with their surgical approach. So, an important thing when making incision, especially on the palmar side of the hand, is to avoid crossing the flexion points. The better way to avoid to go through the flexor is to go around the border of this area that you see colored in the picture on the right side. And in the rare case where you will cross a flexion crease, it's better if you make some Z-plasty to minimize the retracting scar. The other important thing, especially when you're then on the dorsal side of the hand, is to, when possible, make incisions that are longitudinal. So going with the axis of the limb to minimize possible vascular trauma and also minimize some nervous trauma. The last important point, general point, is to anticipate your incision, especially, for example, in Dupuytren's contracture disease. You have to think if you will need to go further and if you will need to have more skin than what you actually have. So you might need to prepare some local flaps to have more skin available. So first thing is when we have wounds on the hand, the best thing on the palmar side is to extend them proximally and distally with oblique diagonal extensions, as you can see on the fingers and on the hand. Whereas, as said before, on the dorsal aspect, you can go longitudinally without any problem. Another important point is to avoid to make two longitudinal incisions, one next to the other, as it might create some ischemia in the flap in the middle of the two incisions. So try to avoid to have two parallel incisions with a narrow flap. So these are the most common hand pathologies, and we will see the most common access to these pathologies. So carpal tunnel. A classic way to see where to have your incision is to go longitudinally between the third and the fourth finger. Another good tip is to flex your finger and go ulnarly to the fourth finger when your finger are flexed this side. As said before, it's better to avoid to crease to not exercise on the flexor crease. And the other important thing while doing carpal tunnel surgery is to avoid both the motor branch and the sensitive branch of the medial nerve. Usually they're proximal and distal, so there is not much risk, but there are many anatomical variants, so it's always better to look for these kind of branches. This is the reason why we don't do endoscopic carpal tunnel release. For trigger finger, a good way to know where is the proximal of your A1 pulley, that is the pulley that you have to release for a trigger finger, is to measure the distance between the crease of the proximal interphalangeal joint and the metacarpal phalangeal joint. So this distance is the same here where you will find the base of your A1 pulley. So you will go, you measure this distance, you report it here, and you have the base of your A1 pulley. While doing the surgery, you have to be careful with the neurovascular bundle of each side, especially when you do a trigger finger of the thumb, as the radial nerve and the radial collateral artery are very ulnar. So your incision must be more ulnar, and you have to be very careful because it's very superficial. So when you incise the skin, look for those artery and nerve and try to avoid them. Then for Becker-Van tenosynovitis, it's what we already told before. We do an incision on the styloid board, on the dorsal aspect of the first compartment. This is in order once it is open to avoid luxation and volarity of the APL and the extensor pollicis brevis. Another thing that has already been said by the previous speaker is that very frequently there is a septum in the middle of those two tendons, and you have to carefully open both compartments to be sure to resolve the clinical situation of the patient. In this surgery, the important thing is once you've done the incision to check for the branches of the radial nerve that will be on both sides of your incision and to try to avoid them. Regarding Dupuytren disease, many different approaches have been described. Most common is the Brunner approach that goes from a lateral side of joint to the other one without interrupting it. There is also Henry Brunner, if the Dupuytren cord is only on the side of the finger, you can stop at the middle and go this way and this way. Otherwise, you have the Eastman, that is a multiple set plastic. It is in the case, as I told you, if you need to extend, if you need some more skin for closure. Otherwise, you have a multiple VY incision, and also a common one is the open palm of McCash. Is in case where there is a big retraction, you just cut, take off the Dupuytren cord, and then leave it open without closing, and it will have a secondary healing. Regarding the trapeziometacarpal arthritis, if you do the standard surgery, so trapeziectomy and eventual ligamentoplasty with some tendons, you go on the dorsal side of the first compartment, between the first compartment and the second compartment. And as I already said before, you have to look for the radial artery that will lay down of the anatomical snuff box. If you do the prosthesis for the trapeziometacarpal arthritis, of course the incision will be a little bit more distal, as we also have to prepare the base of the first metacarpal. So this is for the classic surgery, and this is for the prosthesis of trapeziometacarpal. Regarding the carpal arthritis, it has already been well described by the previous speaker. We usually do a longitudinal incision on the dorsum of the hand, but it can also be oblique or S-shaped. And we do what he said, we usually open the third compartment, we move the extensor pollicis lumus out of the third compartment, and elevate the fourth compartment going under its floor. We have in this way an access to the capsule of the dorsal capsule of the carpus, and this is the Berger flap that he also talked about. It will go longitudinally to the dorsal intercarpal ligament and the dorsal-radial carpal ligament. In this way, when you will close this flap, there will be no risk of dorsal luxation of the bones of the carpus. This is a good access for example, for both distal radius fracture with connected fragment on the dorsal, for proximal rope corpectomy or other kind of intervention on the carpal bones. Regarding the metacarpal phalangeal arthritis, the access is normal dorsally. Usually it's present with arthritis reumatoidis, so a lot of joints are involved. You can either go with a transversal incision in order to have the fourth joint exposed. If only two joints have to have surgery, you can also go for a longitudinal incision in between the head of the metacarpal. Regarding the proximal interphalangeal joint, there are many approaches described, dorsal, volar, and lateral. These are the two dorsal approach. This is the Chamay approach. It's a triangular approach. So it has the advantage to not disinsert the central band of the intermedial phalange. And so you do the incision in this way and you turn back. So this will be elevated this side and you will have a good visualization on the dorsal of the proximal phalange. Now the most commonly used is the tendon split, as it has been demonstrated that the disinsertion of the central band while doing prosthesis of the interphalangeal is not so important, so you can also just split the tendon and then close it. Some surgeons don't like those approaches because you have to immobilize a little bit the patients as the tendon has to heal. So another approach is the volar approach. It's also called the shotgun, as it looks like a gun barrel. It's you open, so you make a Brunner incision, you open the A3 pulley, and then you do an incision on the volar plate this way, and you have to turn your, you elevate the flexor tendons, and then you have to open at 180 degrees your articulation. With this approach, you can do some anterior fracture of the base of the intermediate phalanx or of the head of the proximal phalanx, and then you can also do some joint replacement. Finally, also to avoid to incite to the incision of the volar plate, some authors, like Mazzone, have described the lateral approach of the PIP joint. It goes through the collateral ligament. And in this way, you can avoid both the extensor tendon and the volar plate. But it's quite difficult and you don't have a very good view on the joint. For the distal interphalangeal joint, different approaches are described. I usually use the H1 that allows to have a very good view. This is usually used for the arthrodesis of the distal joint. For metacarpal fractures, so as I said before, the best thing is to use longitudinal incision to avoid to cut veins and nerves that are on the dorsal aspect of the hand. It's better not to go on top of the metacarpal to reduce the rigidity with the extensor tendons. So it's good to go in between of the metacarpal, and this way you can also treat two metacarpal with the same incision. For the Bennett fracture, you can do an L incision on the base of the first metacarpal to fix the fragment of the Bennett fracture. Regarding the phalangeal fracture, you can choose both. We don't use it very much because we prefer to use Kirchner wire, but it is described both on the dorsal side or on the lateral side to put plates. On the dorsal side, you have to, as said before, have a split of the extensor apparatus, and you can put your plate under the extensor apparatus. On the lateral side, it's less traumatic for the extensor apparatus, and it depends on the fracture, but you can have also very good fixation with the lateral approach for the proximal phalange. And finally, for the scaphoid fracture or scaphoid non-unions, we usually distally prolonged Henry approach. So we go long toward the flexor carpi radialis, And when you reach the scaphoid traversal, you go toward the first metacarpus. So you are on the direction of the scaphoid that is just here. So that's the way we go through the scaphoid if we need to put a plate or some bone graft. Thank you.
So we finish this section. We have 15 minutes for break.
I need this.
As if you're presenting. Okay. Just for a while.
Направили на снимка се едно презентирате ясно два фронта практично, так му да не вътрешня докато за секунда. Така. Стойте се малко за секунда. Не, там, не, тук където стояхте по-добре, иначе ви прерязва главата. Стойте на секунда, така, защото аз ще да ви пръснем не в мен, някъде е тук, да.
Тоест,
Добре.
Аз само, че ще трябва да изляза след половин час. За кмет ли ще избираме? За кмет ли ще избираме? Да? Мисля, че First speaker, Brunetto, thoracic outlet syndrome.
Mr. Chairman, dear colleagues, good morning. Thank you very much for the kind invitation to let me to say a few words about the interesting syndrome, the thoracic outlet syndrome. Some old name the cervical rib syndrome, anterior scalenus syndrome, or cervicobrachial syndrome are all the name of the same disease. Many authors gave important contribution to understand this syndrome. Among these, you can find a very important name like Paget, Halsted, Murphy, and Debicki. But the most important one was Pete, that in 1956 introduced the term thoracic outlet syndrome. And but what is the thoracic outlet syndrome? It's a symptomatic compression of the neurovascular bundle at the thoracic outlet. The question is, what is the thoracic outlet? The set of anatomical structures through which neurovascular bundles come out from the chest. So you can imagine that in this short space we can have a compression. A compression against vascular anatomical structures, the artery, the vein, and nervous anatomical structures. So this will lead to different kind of symptoms. So the interscalene triangle is one important anatomical region in which you can find a compression mostly against the nerves. But the costoclavicular space, mostly one of the important, the most frequent, in which you can have a compression against the neuro structures and vascular structures too. And the retropectoralis minor space, in which we can have also this kind of compression. Nerve, artery, and veins, as I told you. The variability of symptoms can cause a debate and misunderstanding. We can have a lot of different symptoms like pain, numbness, paresthesia, headache, weakness, and arm swelling. Time must be taken to fully comprehend the complex anatomic structures of the thoracic outlet region. We can find mostly three combinations of this kind of syndrome because of the compression against the nervous or vascular structures. The neurological is the most frequent, 95%. The venous one and the arterious one, the rarest one. All different effects of the same compression. The compression of a neurovascular bundle at thoracic outlet is mostly against the brachial plexus, the subclavial vein, the subclavial artery, and so because of this combination of anatomic anomalies, physical activities, and life events, we can have a constellation of upper extremity symptoms. The costoclavicular space, as I told you, the scalene triangle and the pectoralis minor space. So here we can have a mechanical conflict against these kind of structures. In the musculoscalene triangle, we can have a wide or narrow triangle with sometimes with the congenital bands and the ligaments that can lead to a compression to the nervous structures, or bone anomalies like a cervical rib. This is quite rare, mostly in female, or mostly on the left side, or the presence of anomalous first rib. In the hand, I will show you one interesting case. So this kind of compression can lead to different kind of symptoms. I used to say this is the land of nobody. The question is, this kind of a problem is a problem of the orthopedic, the vascular surgeon, or the neurosurgeon. Nobody knows it. Predisposing factors: constitution, cervical rib, scalene muscle anomalies, narrow scalene triangle, congenital ligaments, and many others. The symptoms: pain, paresthesia, numbness, weakness, upper plexus disorders, lower plexus disorder, and many others. But mostly also we can have a psychiatric problem, and this make sometimes a confusion among the symptoms of these patients. One of the most frequent is the Raynaud phenomenon, the acrocyanous symptoms, because of the compression of the nervous peripheral system that leads to a vascular constriction. The Paget-Schroeter syndrome is the thrombosis of the axillary subclavian vein, and is mostly associated in the thoracic outlet syndrome. one very old paper from Peter Klovinsky in the Mayo Clinic described this kind of disease with a complete thrombosis of the vein and the reticular venous in the skin. Very easy to understand that have to lead you to think about the thrombosis of the subclavial vein. And some predisposing factors also in the venous type of the syndrome is the clavicular fractures, the relationship between the veins and subclavian tendon, repetitive trauma causing fibrosis, stenosis, and thrombosis, and repetitive activities like this kind of sport. But remember that up to 40% had the residual symptoms after the treatment. So we can find the cervical or anomalous first rib, anomalous anterior scalene insertion, as you see, and the pectoralis minor compression, as I told you. The physiopathology, of course, is the mechanical compression, and the first was described by Alsed in 1916. You can find a lot of symptoms, for instance, pulsatile supraclavicular bruit or digital end ischemia. But let's start to understand how to approach this kind of patient. The most accurate diagnosis of thoracic outlet syndrome must rely on a careful history through to appropriate physical examination. The history, the medical history of the patient is very, very interesting. And no single diagnosis test has sufficient specificity to prove or exclude the diagnosis. The medical history of the patient is very important, as I told you, like neck trauma, repetitive stress injury, occipital headaches, pain over trapezius, neck, shoulder, and many others. Differential diagnosis in carpal tunnel syndrome, ulnar nerve compression, rotator cuff tendinitis, cervical spine, fibromyositis, cervical disc disease, and many others. And similar symptoms you can find also in vasculitis, radiation-induced arthritis, connective tissue disorders, and many others. The physical examination have to look the hand of this patient to examine the pulse, the presence or the pulses, radial, ulnar, and after with some movement I will show you. The electric shocks with the percussion of a nerve to show the upper or lower plexus involvement. This is the Tinel sign. Or very famous, the Hudson test, loss of radial pulse with the head turned, and costoclavicular compression, exaggerated military posture with the shoulder braced firmly backwards. This is the Falconer test. And the right test, one of the most famous, radial pulses in hyperabduction of the arm, head away from the affected side, deep inspiration. The Ross test and the Elvey test, the neuropathy in upper limb down, when you compress the basis of the neck. X-rays is very important to see the cervical rib or anomalous transverse processus of the vertebral, and to see callus formation from clavicle to first rib after fractures. Very important is also the MRI that can see some structures, not bone structures, that can provoke a compression in this short space. So, the arterial thoracic syndrome, you have to perform the duplex scan, the angio-CT, and the angiography. In the venous, the duplex ultrasound and the venography, and also the CT scan to see all the complete condition of the anatomy and the MRI. Very important is the study of the velocity, nerve velocity conduction. So it's very interesting to perform electromyography to approach the patient. But what about the treatment? First, physical therapy. Second, physical therapy. And third, physical therapy too, because the surgery is not always indicated as a first approach to treat this kind of patient. But if the symptoms continue and the patient has not enough relief, probably the best approach is to treat. For the venous one, of course, anticoagulation, venography, catheterized thrombolysis, and PTA of the subclavian vein. But the most frequent used treatment, surgical treatment, is the rib resection, scalenotomy, rib resection, and fibrous band resection. We can find a different approach: the supraclavicular approach, the transaxillary approach, and the combined approach. This is a supraclavicular and also infraclavicular approach. The most important is the skin platysma incision, pectoralis major muscular incision, anterior approach of the first rib, and the scalenus anterior resection. But complications are very important. Subclavian artery vein injury, brachial plexus injury, phrenic nerve injury, thoracic duct, pneumothorax also. So the supraclavicular approach is most frequently used in 77%, and the transaxillary is for first rib resection is not a very easy operation because you have a very short space. This is some paper, very old paper that talk about this scalenotomy. That is, in some time, maybe enough to give to the patient a good relief of the symptoms without removing the first rib. Now, a few cases of cervical rib, you see. Also here. And here is the approach to the cervical rib. This anterior scalenus muscle resected. Pay attention for the upper thorax plexus. This is an intraoperative. You see the rib, the resection. Now one very interesting case, one bone spur of the first rib, you see here. Very, very rare. Please look at the vascular compression, and this is the result. In conclusion, neurological outlet thoracic syndrome is most common and is also difficult to diagnose. The treatment is first physical therapy and surgically anterior scalene block, angio-CT, and the first resection, the resection of first rib. And remember, a surgeon recognizing neurological thoracic outlet syndrome should not be dissuaded to the surgery by the impression that these problems are frequently associated with psychiatric overtone, dependency on pain medication, and ongoing litigation. Any question? Thank you to your attention.
Next speaker, Ganev, Management of Complex Distal Humeral Fractures.
Okay, welcome, dear colleagues, to our city. So, a few words about the more complicated cases of fractures of the distal humerus. Now, first of all, a few words about it. As you know, the examination starts with observation. So you have to have in mind that there are some lines, there are some anatomical parameters that speak of a healthy elbow. Like, for instance, the Newton triangle, which forms a 90 degrees flexion of the elbow joint. In this case, the two epicondyles in the olecranon form a triangle with even sides. Another important light is that in extension, these three elements stay in a line. And also, the axis of the humerus is perpendicular to the two epicondyles, the line that connects the two epicondyles. Any deviation of that speaks of some kind of pathology. Also, we must remember that the axis of the humeral bone is not exactly perpendicular to the articulating surface of the humerus, and it has slight valgacy, giving the possibility for a normal range of motions and daily activities. As you probably guess, not every patient will be adult. Very often children get injured, and that's natural. Now you should distinguish whether that what you see on the X-ray is fragment or just normal epiphysis, a growth region. There is a simple formula, easy for you to remember. You can write down on a sheet of paper these words. Critoe, like you can remember it like the island of Crete, Cretus. All right, you write down Critoe, and you write the uneven numbers 1, 3, 5, 7, 9, 11. So what these words stand for? The first C stands from capitulum radi. So it is the first one that will appear on the X-ray, the first element that will ossify. And usually around the age of 1, between 0 and 3, it will appear on the X-ray. Then around the age of 3 will be the radial head, usually between 2 and 5. Then the internal medial epicondyle, then the trochlea, olecranon, and finally external epicondyle. So, for example, there is a child, he asks the child or the parents, how old are you? And the child says, I'm the age of 3. So what you expect to see is the capitulum radi over here and the radial head. Anything more than that, you can consider it as a fragment, but not necessarily. So you have to take also this. Moving on, this is the classification by our group. Now the more complex case, those we're going to talk about, are the fragmented cases and mainly the interarticular cases. Now there are some two fragmented fractures like this over here, this particular. What should be remembered about them? As you can see, they're divided into fractures of the lateral aspect or the medial aspect. What is important? Where the fracture lines goes through and what it separates. Now to the left, as you can see, it goes through the trochlea and it separates it. The other case, it just separates the capitulum radi. Now the case on the left usually means that this fracture is unstable. It will have tendency for the forearm to go in valgus dislocation if the treatment wasn't related to a stable fixation and right rehabilitation. In other words, you treat it with a cast, there is some chance that this fragment doesn't stay well positioned and the hand will have more valgus than natural. It's simple as this one over here. Now this is from the medial side. The fracture splits the trochlea in two. Again, it will be unstable fracture. This time there will be a pathological varus if the treatment is not correct. These two in the middle, these are stable fracture. There will be no tendency in incorrect angle or axis of the extremity as a whole. Now these over here at the bottom are some very hard to treat, at least in my point of view, fractures. It's because they're interarticular and usually are related with very small fragments like this. In the literature, that literature I came across, it is suggested that you start with posterior approach, take the fragment with the hook, reposition it, and from posteriorly to anteriorly place a screw to hold the fragment. This will be possible if the fragment is big enough, let's say a diameter of about 1 centimeter and above. But there are other cases, like I think it was called Pachul-Renz fracture, where this fragment you see here is just composed of the cartilage and a thin layer of cortex beneath it. So to expect to hold it with a screw will be very optimistic. In such cases, better just remove the fragment and leave the elbow to articulate as it is. You won't expect any consolidation in such type of fracture. So these particular ones, I haven't came across any of them, probably happily for me, but the treatment is very hard, let's say. Moving on. Now these fractures over here, these are the C-type fractures. These are, as you can probably guess, especially hard to reassemble, to treat, etc. With their group, they suggest osteosynthesis. I will show you an X-ray, a picture later. And just to mention something about the proximal forearm. With the olecranon, we have to, and the ulna, we have to take in consideration whether it's two-fragmented fracture or not, whether it's interarticular or not, or multi-fragmented fracture. With the proximal radius, we have to take in consideration how big is the fragment. If it's about, if the fragment is less than the third of the surface of the radial head, then you should remove it. But if it's bigger, you'd better try to osteosynthesize it. Now the principles of treatment in general. So on the left are the principles of the AO group. On the right are some, not all, but some of the principles of Marvin-Tiles of treatment. And in other words, the AO group, first of all, minimally invasive procedure. The smaller incision as possible, keep the muscles as intact as possible, not to talk about arteries, nerves, etc., etc. Anatomical reposition. This is very self-explanatory. You have to be able to do as better anatomical reposition as possible, although that is not always necessary. In every region, there's some deviation that you can allow, which won't lead to any specific lack of motion and not even a bad view for the patient. But these are rare cases. With the interarticular fractures, the anatomical reposition is much more important than, let's say, a metaphyseal or diaphyseal fracture. So stable internal fixation. When you place the hardware, the plates, the screws, it has to be stable. The fracture itself has to be stable. No motions between the fragments, etc., etc. And early mobilization. For the elbow fracture, when you perform the surgery, usually on the third day, it's best to start a passive mobilization, passive physiotherapy. That means the cast is removed, because after you make a surgery, you put a cast, or orthosis immobilization. You remove the cast and start passive flexion and extension of the elbow. This is important because eventually, if it's not done, there is high chance of contracture to occur. We'll speak about that a little later when talking about Marvin-Tau principles. So about 10 to 30 days passive flexion extension. Internal, external rotation can be allowed, but not allowed when there is a complicated fracture of the radial bone, ulna, etc. On the other side, the Marvin-Tau principles are as following. Interarticular fracture treated with immobilization will lead to contractures. If you treat such fracture surgically with hardware, screws, etc., and then immobilization, it will lead to even more severer contractures. So this is why it's very important for immobilization to happen. It's my personal thinking. I believe many will agree that better start mobilization and physiotherapy, and even that it can lead to a secondary fracture, a secondary failure to the osteosynthesis, and pseudoarthrosis, because the pseudoarthrosis might be treated much easier than contracture. But that's personal opinion. Going further, as I said, I will show you the perfect scenario with plates and screws. However, you have many things to consider. Now, how severe is the fracture? This usually correlates with what type of treatment you proceed, what osteosynthesis, how long will be the plate, how many screws, etc., etc. So you open the classification, think about what you should do, and then do it. Then the quality of the bone. Now, with many elderly patients, they have osteoporosis, and such fragments, as you saw in C-type fracture, you can squish them with your fingers. So you should think, what screws can you place in such fragments? How long, how stable they will be fixed? And you'd better think twice before starting such a surgery. Is the fracture open? If the fracture is open, that means it's contaminated. And if you place hardware implants, they are a good environment for the bacterial colonies to start growing. In other words, you should first think of treating this open wound and have signs of healing, well healing, no infection regional, and then perform surgeries. Then, but not to start immediately with osteosynthesis. Is there a nerve damage, vessel damage? When there is such, then the surgery should be more extended, and usually this is an indication for open surgery, because you might decide to treat the patient with a cast or a brace. But if there is a nerve surgery or vessel surgery, you should expose the region of the damage to salvage the nerve or the artery. So, and the patient's age, general condition. Now, if the patient is terminal and he might not live through this operation, of course, you should better not start it. Patient's compliance. Now, if you're communicating with a same person that is ready to cooperate, this is also any indication to start extensive surgery. But if you expect that on the next visitation he will have thrown his brace or immobilization and start doing inappropriate things, you should not think of big operations. This is the best case scenario. Usually what is best are two plates in perpendicular planes to hold that distal humeral bone. And of course the conservative treatment, as we said, if you treat it with immobilization, this will lead to contractures. With elderly patients with very comminuted fracture, you might think of doing such type of treatment. And of course, if the wound is contaminated, if the patient is not suitable for operative treatment. Other solutions, on the right you see external fixator. Now the external fixator is very good decision when we have a contaminated fracture, an open fracture. You wait for the wound to heal, you keep the bones in a relatively repositioned state, wait for the treatment the treatment of the wound to be finished, and then start the operation. You can do this with a cast, but the cast will be contaminated with the pus of the wound, etc., etc. To the left is the direct extension, as you know. Usually there are devices that are mobile, the patient can walk with them. Also a good way of treatment of those cases inappropriate for operation, but uncomfortable for the patient itself and for the hospital team. This is a brace immobilization. This orthesis gives the patient possibility for short range of motion, flexion, extension. This is probably of all the, in my opinion, again, of all the conservative methods, probably the best. And it still depends what type of fracture we have. About the surgery itself, as it was mentioned earlier, the best, probably one of the best approaches for this type of fracture is the transolecranon posterior approach. You cut the olecranon, this is it over here, and then the second stage is to find the nervus ulnaris, expose it well, hold it with the rubber band so that you see it all the time. The risk of damaging the nerve is as small as possible. Then you have to expose proximally the humeral bone. How much will you expose depends on the fracture. A rule is that you have to fix at least 3 screws in a healthy diaphysis. So if the fracture finishes somewhere here, the fracture line is here, that opening is enough. But if it continues upwards, you have to expose more of the triceps. Now you should remember that the nervus radialis should be somewhere here, and the more proximal you go, the more careful you should be when elevating the muscle. After that, these many fragments over here are the first step to be addressed. These are the fragments of the articulating surface. You have to do everything possible to make them one whole fragment. Usually when you reassemble them, you fix them with Kirchner needles transversely, and later through these needles you put cannulated screws. This is the most important thing, to reassemble the articulating surface. Sometimes a small fragment can fall from the fracture, making the fossa olecrani shorter and smaller. It's not a problem, but you have to use drilling instruments or whatever to correct the shape of the fossa so that the olecranon can fit easily and the patient will have a full extension. These are basic principles but important, especially the last one, because if the patient has no full extension, this is a severe complication. Eventually, when osteosynthesis is not possible or the treatment took the worst case scenario, and arthroplasty of the elbow is a possibility. Here is a fracture of the radial head. As we said, it's more than a third of the surface. You should think of how to osteosynthesize it. There is one way to do so, plates and screws. When the the head was too fragmented and not possible to reassemble, you can just resect it and leave it like this. Now, some tests were done with prostheses, but usually they don't give good results, so the prosthesis is not used that much nowadays. The olecranon fracture, shortly for the olecranon, on the left is the Weber osteosynthesis. Now this is a very good way of treatment. It's a dynamic osteosynthesis. That means the motions, flexion, extensions lead to compressions between the two fragments, not distractions. And this is a very physiological way of treatment. However, there are some conditions that have to be made. First of all, the fracture must be interarticular, so through the articulating surface. Second, it should be transverse fracture, not oblique, not going like this or like this, but transverse fracture. Because if you do so, just the fragments would slide between themselves and you lose the effect. And thirdly, it should be two fragmented fracture. If there are many fragments, you can perform this type of technique. In any other case, plates with screws on the right. Okay, thank you. That's all.
Thank you, Pat Kuganev. So the next speaker will be Professor Macauro, bone and soft tissue tumors of shoulder girdle, proximal humerus, and elbow.
Okay, this is the index of my presentation. When we speak about shoulder girdle, we have to discuss that it consists of a proximal humerus, scapula, distal third of the clavicle, and surrounding soft tissue. The whole system constitutes the shoulder girdle, which is very important under oncological point of view because it is the third most frequent site affected by sarcoma, and proximal humerus is the most commonly affected than the scapula. Tumor of the distal third of the clavicle is very rare. We developed a series, published it on International Orthopedics some years ago, but clavicle it's very rare for developing sarcoma, especially for multiple hereditary osteochondroma. May be developed a secondary sarcoma in distal third of the clavicle. But it's very important to remember that proximal humerus may involve osteosarcoma, chondrosarcoma, and Ewing sarcoma, and scapula, chondrosarcoma, Ewing, osteosarcoma, but it's involved by also clear cells renal metastatic tumors. But at the beginning, unfortunately, tumors are extracompartmental at the diagnosis. Extracompartmental means that the tumor grows outside the bone, involving the soft tissue. So it's very important to resect either the bone, either the muscle surrounding it, and it is well known that the covering of the soft tissue it's very difficult sometimes, and currently we use covering by latissimus dorsi or any other muscle to cover the defect after proximal humeral section. So, we remember that the compartmental, the shoulder gill are not only bone and obviously soft tissue, but we have to remember that compartmental, it's not only anatomic discussion, but also functional, because it's very important not only the covering of the muscle, but also it should be important the fascia, because the fascia is a strength tissue in comparison to the muscle one. So when we resect bone and muscle, for example, we have to consider not adequate surgery, but marginal surgery, because the muscle moves with the electrocauterio. It's a common observation for us. So we remember that the really compartmental surgery is very difficult in the girdle. It's most common, for example, in proximal femur, because we have fascia lata. It's a very thickness tissue. So hard tissue. It's a good covering for the resection. While in the girdle, it's quite difficult to obtain it. In fact, the growing of the tumors go outside the bone, going towards the muscle. But the muscle, it's a very, very soft tissue as well, the fat one. So when fat tissue or muscle tissue covering the tumors, we consider marginal resection more than adequate resection or wide resection, because wide resection needs thick tissue, not soft one. The mechanism of spreading, it's very common. The tumor growing outside the bone. So what are the indications for the limb sparing surgery in the girdle one? So obviously high-grade tumor, some low-grade malignant tumor, benign aggressive one like sometimes giant cell tumor. It's the typical benign aggressive tumor, or chondromyxoid. So it's or some chondroblastoma that are benign local aggressive tumor, that sometimes require resection. Usually we prefer, obviously, interlesional curettage, but sometimes, in case of recurrence, resection should be needed. And sometimes in the metastatic tumors of the proximal humerus, especially when we have pathologic fracture due to the carcinoma. But absolute contraindication of limb sparing surgery is the involvement of the neurovascular bundle, or patients that are not candidate to limb sparing surgery. In the past, we considered contraindication also the chest wall extension or pathologic fracture, but now, or previous infection, we consider now no more absolute contraindication. Obviously, it's a relative contraindication in the presence of infection. We have to cure it at the beginning of the infection, and then we can use resection and modular prosthesis reconstruction. But obviously, in that case, limb sparing surgery is absolutely contraindicated. Preoperative evaluation require bone scan, MRI, CT scan. Angiography and venography is less important. Angiography is only important in case of preoperative embolization that we use currently in case of renal tumor and the thyroid tumor and some vascular tumor, but usually angiography is not necessary for the planning of tumor resection. It's very important to do the biopsy. The biopsy should avoid in the layer between two different compartments. The interstitial should be avoided in case of biopsy. Biopsy should go towards the muscle, towards the compartment. It should be done close to the tumor. Obviously, we today analyze a different approach, anterior or posterior, but the biopsy should be done where is the tumor. If the tumor is anterior, biopsy should be done anteriorly. If the tumor is posterior, obviously the biopsy should be done posterior, close to the tumor, not far from it. And either anterior and posterior should be done depending on the extension of the tumor. We prefer, obviously, for interarticular resection of the proximal humerus, the anterior one, but in case of the tumor in the scapula, obviously posterior approach should be done. And anterior approach is currently used also in case of benign or low-grade malignant tumor, as well low-grade chondrosarcoma or giant cell tumor, in which intralesional treatment should be done. We open the tumor, we open the wide window, we do curettage with curettes and with high speed, and we fill the cavity with usually bone cement or bone coming from the bank. These are the classification of surgical resection, depending on the extension of the tumor. If the tumor is inside one bone without soft tissue extension, or in case of soft tissue extension close to the tumor but not involving the joint, we use intraarticular resection of the proximal humerus. Intraarticular resection with the scapula sparing the joint, but usually I prefer total scapulectomy when I do the resection of the scapula. Because in the glen usually the tumor grows surrounding the bone, so we have high risk of local relapse using with partial scapulectomy. Partial scapulectomy should be indicated only in case of the tumor developing in the distal part of the scapula. So we do an horizontal scapulectomy, saving the joint. It's very, very useful because the function is completely normal in that cases. But most challenging are the extraarticular resection involving total scapula in the proximal humerus, total scapular and distal third of the humerus, total scapula and total humerus. It's very, very challenging surgery. But depending on the growth, the biological behavior of the tumor, grading, the stage, and obviously the response to the adjuvant. But it's the most common surgical treatment is the resection, type 1 resection of the proximal humerus, not involving the scapula, not involving the joint, and we use resection and reconstruction with modular prosthesis, endoprosthesis, or more recently sometimes also reverse shoulder arthroplasty, but I recommend at the beginning not to touch the glenoid in order to avoid the risk of local relapse involving also all the scapula. So it's better to use endoprosthesis at the beginning. Mesh should be recommended in order to reattachment the soft tissue and especially the rotatory cuff. I spoke about partial scapulectomy. I do not recommend it. It's because it's very difficult to understand where is the real margin of the tumor. We remember that to have wide margins, we have at least 3 centimeters in the bone in order to be wide surgery in bone, but glenoid it's very difficult to understand if it is involved or not, and especially MRI planning before should not give all the information regarding it. So I recommended total scapulectomy it's safer in order under oncological point of view, but it's quite difficult under functional point of view, because without scapula we have a wide limitation in the function. The upper limb go no more than 30 degrees, and we completely avoid the abduction. But it's safer under oncologic point of view. I do not recommend the reconstruction in case of total scapulectomy. Even if some devices should be developed for the so-called aesthetical reconstruction of the scapula, but I do not recommend it because the function is quite similar to the not reconstructive scapulectomy, and when we have high risk of infection. While I recommend the anchorage of the soft tissue to the clavicle after the total scapulectomy, because it's under functional point of view, it's completely similar to the aesthetical reconstruction of the scapula. This is a case operating Ewing sarcoma of the scapula. You can see the involvement is close to the glenoid, so I planned the total scapulectomy after open biopsy, chemotherapy, and this is the wide surgery because you cannot see any tumor, but we have a very important cuff of muscle surrounding the bone. But I remember that muscle should not consider a really wide margin when we do surgery in case of resection of the scapula. And then if the tumor go anteriorly from the scapula, it's close to the ribs. So it's quite difficult to understand really wide margin. Usually we have a marginal resection anteriorly and wide resection posteriorly when we do a scapulectomy, because we cannot go toward the ribs. Maximum we can do the we remove from the ribs, we remove the tissues, but we cannot remove all the ribs for obtaining a wide margin anteriorly after scapulectomy. So quite difficult, but the easier Tykov-Lindberg procedure is proximal it's a total scapulectomy and proximal humerus, but usually we do proximal humerus and the partial scapulectomy anteriorly. When we do proximal humerus resection and we have the doubt that the tumor go inside the joint, we can do totally glenoid resection anteriorly, the resection of the glenoid, and anchoring with a prosthesis with a mesh onto the remaining scapula. It's easier procedure. Proximal humerus and partial glenoid resection. On the contrary, when we do scapulectomy, I suggest to do complete scapulectomy, not partial one. Extra-articular resection required an approach more medial than the usual approach for proximal humerus. When we do only proximal humerus, I recommend anterior approach, obviously not going into the deltopectoral, because when we open the deltopectoral approach, we contaminate both the compartment, either the deltoid and the pectoral one. So I recommend to go towards the deltoids. But when we plan extra-articular extraction at the beginning, the skin incision should be done more medial, because we have to develop the tissue from the coracoid muscles. The tendons, conjoint tendons, should be moved laterally, because medial we have to control the vessels. when we do extraarticular or total humerus resection, I recommend to go more medial in order to move the joint tendons laterally and the vessel medially. The control of the vessel is very important for going on surgery. Okay, this is the resection. Okay, obviously when we do scapulectomy, we do towards the muscle. We open. It's very important to reach the distal angle of the scapula in order to move it from the distal to the proximal one and go toward the muscle along the ribs. It's very important to obtain the anterior margin of the tumor. It's not important. This is the when we do how do you reconstruct the humerus? You use proximal humerus reconstruction, modular prosthesis, anchoring with to the clavicle if the tumor involved the glena. Otherwise, it's not necessary to anchoring the proximal humerus to the clavicle, because using the mesh, thanks to the mesh, we have the opportunity to close the muscle after resection to the proximal humerus. This is a case of a relapse of a myxophibrosarcoma in old patient. I planned total humeral resection. You can see the margins proximal when we have the relapse of the tumor. Usually the tumor does not involve the joint, so we do intraarticular resection proximally, and the distal and the total humeral resection, and reconstruction with total humeral replacement and flaps. I do not recommend aesthetic reconstruction of the scapula, I remember, because we have not any functional results. Scapular prosthetic reconstruction, it's very it's very important, because the society developing products try to convince doctors to use this kind of prosthesis, but I do not recommend it. According to Winkelmann, he told me that, no, Giulio, you can, because functionally it's not, it's completely similar to the total resection and without reconstruction, and we have less infection. So I think that's very important to the soft tissue reconstruction, either using mesh, either using flaps. This is another case. It's operated with Professor Rosa some years ago. A relapse of a fibromyxosarcoma in 54 in an old man, 54, no, not old man, less than me, younger than me. So young patient. Yeah. But it is a relapse after different surgery and after radiation therapy. So this is the relapse with calcification. This is the relapse involving scapula and involving proximal humerus. So we plan extraarticular resection. This is the scar after radiation therapy. In that age we have not plastic surgery inside. We have not the possibility to do the flaps, so we plan surgery without reconstruction in order to obtaining soft tissue coverage. This is the tumor, the specimen after resection. This is the postoperative X-ray after resection of the scapula, of the proximal humerus, and the lateral third of the clavicles. But this is the function. So, very nice in comparison to the basic situation. So, I remember that when a surgery approach a surgeon approach tumor, he should do also not only resection but also amputation, because amputation it's a modality of treatment in case of not conservative cases, in case of tumors, but also in case of tumoral complication or vascular or nervous damage or not possible limb sparing surgery. Four-quarter amputation, it's very, very important. It's I remember that we need at the beginning I suggest not the fracture of the clavicle. I suggest a resection of the medial third of the clavicle, isolating the vessel, ligating it, infiltrate the nerves, and then resected it, and then we do the resection. But at the beginning, the first step is to ligate the vessels. And we conclude with the distal humerus tumor of distal humerus. At the beginning, we discuss about the approach. Obviously, in case of tumor, the approach should be done. Where is the tumor? This is the approach. You should do either anterior, either posterior approach, because where is the tumor, there is the surgery. So in that case, we resect distal third humerus through anterior approach, but usually if the tumor is posterior, you can do also the posterior one. So thank you very much.
Thank you. So the next speaker is Professor Stavrev, surgical treatment of malignant bone tumor of upper extremity. Our experience.
So it's quite difficult after this long talk about tumors of the upper extremity to continue, but I'll be short enough. I want to share our experience of the Department of Orthopedics, Medical University Plovdiv, with surgical treatment of tumors of the humerus. With this presentation, we want to share our experience. And we go straight to the cases. This is our first case, 78-year-old lady with a big tumor in the proximal part of the humerus. We did X-ray, we saw this big formation, compressing the vessels. We did a CT, and what we noticed on CT, on the computer tomography, is that the vessels are only compressed and they are not inside the tumor, which is good. So this is the coronal view, this is the other view. As you see, quite big, but only compressing the vessels without engaging them inside, which is good. So we decided, let's take this tumor out. The lady was already biopsied, and they have offered her an amputation of the upper extremity in another hospital. She was 78 years old, and she did not accept the offer for amputation. So we decided to resect the tumor with sparing her upper extremity. This is the tumor, quite big as the head of a baby, but luckily only compressing the vessels. We already had histology. It was myosarcoma, but well differentiated with slow progression. And this is the drainage after the total removal of the tumor with clean margin, as Professor Makoro mentioned. This is another case of ours. This is a comparatively young man, 60, with quite big formation, again in the upper part of the humerus. This is the CT with contrast media, Again, luckily, only compressing the big vessels without engaging them inside the tumor. So, again, the patient didn't accept amputation, which was offered in another institution, so we decided to do a limb sparing procedure. Luckily, the deltoid muscle was okay, and if you remember from the previous lecture, the main abductor of the shoulder joint, this is the deltoid. Unluckily, the other muscles of the rotator cuff were engaged in the tumor, so we had to remove them. I mean the suprainfraspinatus. So we decided to implant the prosthesis. So this is after surgery. We implanted a reverse prosthesis. This is called a reverse shoulder prosthesis with a long stem. This prosthesis is called arrow prosthesis, French one. This was possible because, as I told you, the deltoid muscle was okay. So we could spare the extremity. And this is the resection level. From here upwards, everything is a prosthesis, and from here downwards, this is the stem of the prosthesis. Results. For evaluation of our results, we used the MSTS system. The first case was 90% score, which is quite good, but this score is okay because we didn't implant any prosthesis. The second patient with the reverse prosthesis, in accordance with the MSTS system, was 66%. So when we do the surgeries, we must think about the longevity, how long will the implant survive. Our cases, only 2 cases that we present, were lucky cases because the neurovascular structures were only compressed and not inside the tumor. And we managed to do a salvage procedure and to avoid the amputation of the upper extremity. In 2021, Christian Schneider and co-authors published a presentation about the longevity of the shoulder tumor endoprosthesis and their functional result on the basis of 154 patients. And we do not have such big series. And what he concluded is that the patients that were treated with tumor endoprosthesis survived more than the patients who were with amputated extremities. So this was interesting to find such case. This is another presentation done in a Turkish hospital with an implant produced in Turkey. So Professor Makauru told us that he doesn't like this implant. But anyway, when you do not have any muscles, this is a possible implant. So they say that they have treated 55 patients, and out of them, on 18 of them, they have implanted this implant, substituting the upper part of the humerus. And they also reported for a very good survival. But anyway, these are not our cases, but other cases. This is the Maryland University statistics. So again, we have better survival of the patients treated with limb salvage procedure than the patients with amputations. So another study showing that the limb salvage procedures patients live more than the patients with amputations, probably from the better care. Another citation, and this is another interesting study performed in China, in the city of Xi'an, China, where they used a vascularized fibular graft to substitute the proximal humerus in children, and they even evaluated the growing capacity of the fibula. So they have said that the graft grows with 4.4 millimeters per year. So they even managed to preserve the growth of the humerus. So China is a big country with And we mustn't avoid their experience. I mean the Chinese experience. Despite the doubts of some authors, we consider that the limb salvage procedures, if it is possible, is the proper way of treating of these tumors of the upper part of the humerus engaging the shoulder joint. So in every case where we can spare the limb, we try to do it, and we try to avoid the amputation. I think the same thing mentioned the previous author, Professor Macoro from Italy. Thank you.
Okay, the last speaker today, Professor Macoro.
I will present on behalf of Professor Macauro.
Wrist recurrency of GCT, this abbreviation, I don't know what does it mean. Custom-made prosthesis, first case in the world, yes.
So it's a giant cellular tumor. And it's a case we operated on in May with Professor Macauro, Dr. Zirano, Dr. Padaya, and with the help of Dr. De Fazio and Dr. Channi. Okay, sorry. So there are general informations about giant cell tumor you can find in the books. We'll try to go fast. This is the story of our patient. Now, when we treated her in 2023, she was 36 years old. Her story starts 10 years prior with diagnosis of giant cell tumor to the distal radius. She had, during the years, many recurrences with many surgeries with curettage until 2017, when she had her third recurrences, and she underwent the resection of the distal radius and an arthrodesis of the ulna with the carpal bones. So these are some of the images during her story. This was after the second curettage of the distal radius, and this was after the resection of the distal radius with the ulnocarpal arthrodesis. Unfortunately, in 2022, she had further recurrence. This is a 3D reconstruction, so the pink part is the tumor. And what did the literature say? So the principal indication would have been for forearm amputation, but she was 36 years old. The tumor seemed not to have implied the soft tissue, so we had to think about another solution. We decided to make a custom-made prosthesis, arthrodesis prosthesis. So this is the model. And so this is an intraoperative piece of the tumor with the 3D printed model that we used during the surgery. And as said by the professor, we had to go, sometimes you have to follow the tumor. So we had to go both volar and posterior approach. So this is the video. I don't know. It's quite a long video that will resume the surgery. So this is the volar approach. So we had to go volar because, of course, as we could see before on the reconstruction, the main part of the tumor was volar. It was, we will see later, it was quite difficult because the tumor displaced all the soft tissue. So all the anatomy we have studied up to now was completely different from what we could expect. So this, of course, take us more time. Here we can see, and it's not very clear, but this is the median nerve that was completely displaced medially, and all the other structure we had around were very difficult to recognize and to separate from the tumor. So here, this is the tumor. We can see the tumor here, this gray part. Here is the ulna. During the planning, we decided with the technician of the prosthesis that we would have to go 2 centimeters proximal to the edge of the tumor. So that's why we're preparing the bone at this level to make the cut, to take off the, make the tumor excision. Of course, as I told you, in 2017, this patient underwent an arthrodesis, and the arthrodesis was made with some rush wires, and to take off the rush wires, we had to go distally. This part was also a quite complicated part of the surgery, as those rush wire implanted have been there for 6 years, so it took a lot of time to take them off. The approach is the one we explained before. Here we can see the extensor pollicis longus, and so we elevated the 4th extensor where the extensor communis of the finger are, and we went under it. So this is the part with the extraction of the pins. Here it seems very easy, but this is after 30 or 40 minutes of war against the pins. But we finally managed to take them off. Because once the pins were removed, we went back to the volar approach, and we performed the proximal resection of the ulna. Then the prosthesis that we have taught with the technician to be sure to be in tumor-free bone had to, as foreseen, the resection of the proximal metacarpal of 2nd to 5th finger. So once the proximal resection was performed, so here we can see now the proximal resection was performed, the tumor is freed from the soft tissue around it. The next step that we will see just after is going back to the dorsal side and prepare the metacarpal. So here with these needles, we are looking for the intermetacarpal spaces. We also used radioscopy to have to be sure that we were in the right place. So here we're placing the needles in between each basis of the metacarpal of the long fingers. So then we went back volar to free the volar aspect of the basis of the metacarpal. Still, when we planned the prosthesis, as I told you, we planned to cut 2 centimeters from the basis of the metacarpal. So here it's what we're doing. We're measuring. I think this is the 3rd metacarpal. So we're measuring 2 centimeters from the beginning of the basis. This needle here is to sign the carpal metacarpal intersection, and once we have signed all the fingers, we start to cut them, and then we use the 3D printed model that we had sterilized for the surgery to be sure that our measurements were right. So now we have this cut here, and you will see now we will take the model and put it at the level of the cut to be sure that it's the right measures. This is the 3D printed model of the resection. So here is where we cut. We put this to be sure that this this was the right spot that we measured before. So then we cut the second, the third, the fourth, and the fifth metacarpal. So once all the metacarpal were cut, we went finally back to the volar surgical approach to detach the last pieces of the tumor. And this is the ulna, the proximal carpal bones, and the proximal metacarpal, and the tumor around it. And then we had to start with the preparation of the remaining ulna and the metacarpal to implant the definitive prosthesis. So here is the preparation of the ulna. As with other type of megaprosthesis, so everything was already measured before the surgery, but in case we had to go further, we also had the possibility to add some length with some 1 centimeter modules that we could add to the prosthesis if the length of the prosthesis was not the right one. But we didn't need them. At the end, we managed to use the size that were thought before the surgery. So this also, as before, this is the 3D printed model that we are trying on just to see if the length of the prosthesis is correct. So this is the model of the ulnar part of the prosthesis. And now we will put the remaining part of the model just to check if the length of the forearm and of the end is correct. You can see on the back the extensor tendon, extensor common tendons. So this is still the 3D printed model. Now you can see it's inside. It's not fixed, just to have an idea if the length of the prosthesis was right, and it seems okay. There was no tension on the soft tissue, and it was not either small, so it was perfect. So then we prepared the metacarpal bones. We prepared them with a big K-wire, and because what the industry had predicted for this part of the surgery was just to put screws inside the bone, so we didn't have to prepare them too much so that the screws could fit in the metacarpal. So here you can see one of the screws that is inserted inside the metacarpal bone. Once all the 4 screws were inserted, we took the definitive prosthesis and we put it inside. This is the definitive stem. So what I told you before is eventually if we needed we could add some modules here, but we didn't need it. And so this is the definitive prosthesis. We fixed each metacarpal on the carpal part. There were some blocking screws on the dorsal part of the prosthesis. And maybe as you've seen, so this is the screw to block the metacarpal. As you've seen maybe before in the planning, so we cut the 2nd to 5th, and we left the first metacarpal bone. So we were thinking, here's what we're doing, what to do with the thumb. So when we thought about the prosthesis, we asked the technician to make 3 holes here to make a ligamentoplasty, same type we do for rhizoarthrosis. So we take a tendon, we take a part of the abductor pollicis longus, we pass it through one of this hole, and we put it back on itself and suture it to itself. We will see it soon. So now it's inside, and then it has been sutured to itself on the other side. So here is the tendon that is sutured to itself. It gave good stability, but of course, from the previous surgeries, the patient had already a deficit of flexor pollicis longus, so she don't have the full movement of the thumb, but she has, I will show you after, some good result anyway. And this is the end of the surgery with the suture. Okay, sorry. And so these are the post-operative X-rays. It looks a little bit like Wolverine, but I think it's a better option than amputation. And these are the 6 months, a few weeks ago, 6 months follow-up results. So of course, she can't move her wrist, but she has good flexion extension of the finger, except from the tub. But she managed, with other finger, to have a good grasp, and she managed to use commonly objects during her daily life. So I think it's a great result. And avoiding amputation in young people is always a good solution. And this is the team. Thank you.
Thank you. This was the last lecture presentation. So it's your time for questions. We have 15 minutes for discussion. If you are ready with your questions, we can start. Anybody? If you're not quite sure with the question, you can do this tomorrow during the last discussion. We'll have more time tomorrow. So if there is no question, we can proceed with the lunch. I think it's most of you prefer this. Okay, thank you.